Good morning. Good morning, Massimo.
Morning. How are you, Manny?
Very good.
The camera works. Doesn't work. I gotta have another camera here.
The camera is not coming on.
Sir, we are live now, sir.
Yeah, Dr. Massimo, can we check the slides, sir?
You want to check the slides? Yes.
Yeah, so that it's more, yeah.
All right. Let me see if I can share first. You see my slides?
Yes, sir, we can see.
Okay. Can I leave it on?
I will be showing one or two slides.
Okay, so I can stop sharing, right?
Yes, please.
Yes,
All
sir.
right.
Yeah, thank you, sir.
Hi, Shamala.
Hi everyone, how are you?
Hey, good morning. Good afternoon. Good evening.
Hi, Shamla.
Hello, how are you?
Good, thank you.
Morning. Good morning.
Morning. Good morning. Yes. Good morning.
I know it's different times in various zones, so it was.
But it's remarkable you were able to put together this program on different time zones, really different time zones.
Thank you very much, Dr. Massimo.
Yes.
So just saying hello, this is Sevanti. Massimo, we have 111 delegates already logged in and more coming through. And in a minute, Dr. Prashant is going to start the introductions. I see Dr. Govind Babu sir here. He's going to talk right after you. And of course, Dr. Maheshwaran.
So I can see Rick is also here. Hi,
yeah,
Rick.
Rick is also here. Yeah.
Oh,
Hi, Rick.
Hi, Rick.
Hi.
That's a different time zone.
So we got almost 600 registrations, 600. And I'm expecting almost 1,000 people connecting across world. So we got people from all over world.
Wonderful.
Yeah.
Fantastic.
So this is great. Hi, Dr. Nanda.
Hi, Dr. Prashant.
How are you?
I'm good.
So Dr. Sevanti is here.
Yes, I'm very much there with you, Prashant. All three of us that are there. Mani is waiting on the other side.
Yeah, Mani is there.
Yes, Prashant, all yours.
Yes, thanks. So we will start in a minute. Dr. Sevanti?
Yes, so countdown has started. It's 6:59. You have 1 minute to go, then we can go ahead.
Sevanti, hello. Mani, should we start?
Yes, Prashant, I think we should start now.
Okay, let's go. So, hello everyone, dear friends, colleagues, and students. Wish you all a very happy new year. Last year was not an easy year. However, it definitely bonded people on virtual platform. It is my great pleasure to welcome researchers from academia, industry, and clinicians from all over the world who are working in the area of liquid biopsy to this meeting. Liquid biopsy, a game changer in cancer evaluation and treatment. The three main focus of our meeting is management of rapidly progressing cancer using liquid biopsy testing benefits in cancers, limitations of liquid biopsy in cancer progression and monitoring. I truly believe liquid biopsy is a fascinating and exponentially growing field and has a tremendous potential to significantly change the therapeutic strategy in cancer. In patients, providing an extremely powerful and reliable non-invasive clinical tool for the individual molecular profiling of the patient in real time. We have invited and short talks by leading international and national experts who have also proposed, we have also proposed day 2, a panel discussion. The main aim of the meeting is to bring together, again, researchers from academia, clinicians, and the industry to present, discuss, and share the latest information on liquid biopsy. We look forward to presentations, stimulating discussions, and sharing of the data. A highly motivated clinical mass of the participants from all over the world will have the chance to interact, establish collaborations, and present their latest data in a unique, relaxing, and stimulating environment. I must thank my other conveners who really helped me to shape the meeting. Dr. Sevanti Lemay, she's a Director, Clinical and Translational Oncology Research, Director, Precision Oncology at Kokilabehan Dhirubhai Ambani Hospital, Medical Research Institute, Mumbai, India. And Dr. Sundarai Mani, he's a professor in the Department of Translational Molecular Pathology at MD Anderson Cancer Center, also co-director of the Metastasis Research Center, as well as the Center for Stem Cell and Developmental Biology at MD Anderson Cancer Center. We three again welcome all of you for this exciting session. I'll quickly brief you about the liquid biopsy. Could you please share the slide? So something very interesting, why we put the name liquid biopsy, a game changer. And what you could see that the liquid biopsy, what is something it is bringing, that it is not only screening the early detection of the cancer, but you can do the real-time monitoring of the therapy, risk for metastasis relapse, therapeutic targets and resistance mechanism, stratification and therapeutic interventions. So this is where you could see the different arms, different dimension, which you could use applying liquid biopsy. When we talk liquid biopsy, so it is something, the biopsy where it is an invasive process and the patient has to go through the surgical intervention. What liquid biopsy eventually give you a source which you would actually achieve using any liquid media. And it is not necessarily blood, it could be saliva, it could be fluid effusion, urine, CSF. Next. So most of the talks you will see and you listen next 2 days, based and the experts will talk, I would say, mainly on the CTCs and ctDNA. And a very basic difference, if you see, when you collect the blood, what you see that there are two layers. The first layer, and which is the upper layer, where you would expect the plasma and the DNA. And this is where we are actually reaching to get the DNA for further analysis. However, the lower level, you could see the cells are getting sedimented. And this is where we call it circulating tumor cells. Now, what you would see that either you use CTCs or ctDNA, what you are going to get is the information. And the information I was talking, it is DNA. And if you got the DNA, what you could eventually further process it you could identify the amplifications or the deletions or translocations or the point mutations. The CTCs, which gives us a little head, I would say, of course, you would identify, you could isolate the DNA from the CTCs, but what it also give you an edge to understand the biology of the cells. You could also do the proteomics because you have the cells, and you could check the proteomics or the post-translational modifications, maybe the phosphorylation. And of course, you could culture these cells in vitro conditions, and you can amplify the cells. So the goal of CTCs or ctDNA is, or the liquid biopsy is that what we are dreaming is the personalized therapy. And this is something very interesting. You could see this example where what you could see, there's a population, which is mixed population. And for the clinicians to address the population, if you go through any of the cytotoxic chemotherapeutic drug, you would always come up with the two set of people who would respond to the therapy and who may not respond to the therapy. So what eventually we would achieve, going in details, we would identify those patient cohort who would be benefited eventually in a larger way. And you could see that the targeted agent, if we could identify for a cohort A or cohort B, that would reach, and this is where we call it that the therapy will be individualized. And this is where I could see that we are heading towards. So I will just end my introduction, and I will just bring Dr. Sundari Mani. So just to talk about Dr. Sundari Mani, Dr. Mani has received numerous prizes and awards for his research, including Zimi Foundation VS Scholar Award, American Cancer Society Research Scholar Award. He has recently been elected a fellow of the American Association for the Advancement of Science. He has done tremendous work in the area of EMT, and he is one of the first to demonstrate the cancer cells acquire stem cell properties by activating the latent embryonic EMT. So I'm really pleased and welcome Dr. Mani Sundari to take the charge, and please introduce Massimo. Thank you very much.
Thanks, Prashant and Seventy for, this is a spectacular meeting. I'm sure the participants will benefit a lot. And again, I just want to share some, just 2 slides and 3 slides. So as the name indicates, it's a we are really witnessing how the liquid biopsy is really changing the way we diagnose and treat patients. This is a spectacular program. And most importantly, it's not that just the liquid biopsy is a game changer. The speakers, what we have here, are all they're all also game changers in this area. So my friend and Massimo Cristofanelli, he was here at MD Anderson. Now he's at Northwestern. He's a professor, and so he has really played a big role in really doing a game changing in this area as well, in particularly in CTC, now in ctDNA. Probably many of you may remember this paper where Massimo was the first one to demonstrate that the circulating tumor cells have clinical benefit. In other words, you can use circulating tumor cells as a clinical biomarker to separate patients into those who are at high risk versus those who are at low risk. And if you go to this Web of Science and search for articles, and then if you rank them based on citation, one of the most highly cited article is this one, Circulating Tumor Cells by Massimo Cristofanelli in the New England Journal of Medicine. And you can find a lot more about Massimo. You can find all his articles as well in this Google Scholar. He's one of the most respected professor a clinician, a scientist, and a good friend. Again, without further ado, I welcome Massimo to this game-changing conference, a symposium. Hope you all will enjoy. And without further ado, I pass the podium to Massimo. Thank you, Massimo. And thanks everyone for participating.
All right. Well, thank you so much, Manny, for the introduction. Obviously, we are very good friends for a long time now. And the friendship started when I was at MD Anderson. When I was at MD Anderson, really starting the field of CTC. But that was a team effort. I would say that I cannot get the credit only by myself. You need to have the right environment in order to make major discoveries. And today I also represent the International Society of Liquid Biopsy, because why we all recognize the liquid biopsy is changing together with new therapies, of course, the way we manage and we change lives of patients. We certainly need to have a major international effort, bringing scientists, clinical investigators, as we just say, and the industry, the diagnostic companies as well. So I want to just go for a few seconds on these slides, because this was the first paper, but it took now 16 years to get to the point where we are right now. Meaning that when you introduce...
Massimo, can I just interrupt? If you could just change the display settings. Right now, both the next slide and the current slide is showing up. If you click the display settings and the top, and the top, and the top, and the top, just one to the left. Yes, that one, click that. And then you change to maybe...
There you go. I think we are, right? Yeah, technologies. We're still trying to develop skills for that.
Thank you.
As I said, if you see the slides right now, everything is fine.
It's still to slide.
Can we select? Yeah.
So I think it cannot be played in the presenter mode.
Oh, you cannot? Oh, okay. Okay.
It's okay. Right now you see it?
Not yet.
So you need to share the screen once again.
Okay.
Massimo, I think it just cannot be played in the presenter mode, just slideshow, regular slideshow.
Slideshow, yeah.
Yeah, slideshow. What about this?
This is going to presenter mode.
Yeah, in the display settings, we can change select the second option on the top, the display setting, the second option. So duplicate slideshow. Yeah.
Okay.
Yes.
Everybody can see?
Yes.
Right.
I think.
So it took 16 years to get to this point. And I think the reason is that when you have a new tool, you really need to learn how to use the information. And as you know, many have tried to explain how to use the CTC enumeration in the clinics. Now it's not moving. Oh, here you go. Well, what's important to see that just recently this was recognized as a major milestone in cancer, because it started the liquid biopsy from the CTC to CTC molecular characterization, and most recently to cell-free DNA, exosome, extravesicles as well. So in order to better understand how to use the CTCs in the clinic, we have noticed that, for example, CTC enumeration predicts the development of metastasis. So our hypothesis was that, in fact, a stratification based on CTC, we identified two different groups of patients with a stage 4 aggressive and stage 4 indolent, irrespective of the site of recurrence, de novo versus recurrent, subtype of disease, and line of therapy. How we started to work on this hypothesis. We took the European Pool Analysis Consortium data of more than 1,900 patients, the MD Anderson database, fully clinically annotated 492 patients, or more than 2,400 baseline characterization enumeration of CTCs, And the hypothesis was, if that was the case, we can stratify the patient irrespective of the type of disease. You can see on the right side the stratification to de novo, and in the recurrent disease, essentially same prognostic impact on overall survival, irrespective of patients you are evaluating. Most important, in the disease subtypes, we always think that estrogen receptor positive patients are in fact the one with more indolent disease, but you can actually see that it's true that if patients do not have more than 5 CTC, have an overall survival up to 44 months, but if they do, their survival is about 17 months. And this is irrespective of the treatment, of course. Patients were treated either with chemotherapy or endocrine therapy, whatever their physician felt. So this is important now, if you think about in the context of we use a CDK4/6 inhibitor for everyone, what's the impact on this? And we are moving forward an analysis, for example, the Monarch 2 that we hope to present at the next ASCO meeting. And when you look at the distribution of the findings across the different type of disease, recurrent sites, line of therapy, you see there is no difference. Even if you have a bone-only disease, that's remarkable. Enumeration is still a strong prognostic factor. This means that we cannot treat the patients the same way irrespective of the CTCs, and obviously indicate that there is more need for molecular characterization to select the best therapy, because the SWOG studies show that simply changing therapy is not going to impact the long-term survival of patients with CTCs. So at the last San Antonio, you may recall, there was a presentation that was instead looking at the clinical utility of repeated circulating enumeration, mostly looking, in fact, at the predictive value. Is the therapy working or not based on the change of CTC number, without, again, looking at the specific of the therapy. And this was another pool analysis, was a major effort. All the CTC investigators from Europe and the US and other countries, they participated in a number of studies, prospective studies, and studies that have really collect very careful clinical data. And this was, again, the focus was on the predictive power on different breast subtypes and clinical setting. Important, they were not only looking at the CTC cutoff of 5, but also the cutoff of 1. So you see the baseline distribution on CTC with respect to the more than 1 CTC and more than 5 CTC. So essentially, when you look at the more than 1 CTC, 72% of patients had more than 1 CTC, and 47% at baseline had more than 5 CTCs. And you see that there is a trend in the decrease of the CTC based on the different cutoff in the follow-up after the therapy around 9 days. And this is the overall survival according to the CTC at baseline. And once again, you see that obviously there is a difference between the 0, 4, 5, 25, and more than 25. Clearly, the major difference is with the 5, but even the 1 to 4 seems to have a worse outcome, meaning that the presence of any CTC, and we are talking about epithelial cells by the soul search, may have an impact on survival at baseline for patients with different subtypes. And important, you see the first follow-up, the most significant information are in fact, if you are negative and remain negative, you have a median overall survival of 47 months. And if you remember what we show in the baseline, less than 5 in a year positive, we are around that number. So these patients do very well. If they were negative, remain negative. Obviously, if you are positive and remain positive, it means that your therapy has no impact. More than 1,700 patients, and the median overall survival is around 17 months. So similar to what we are seeing in the other numbers. But there is a possibility to switch, to go from positive to negative and improve the median overall survival. And I would say that this group of patients may well represent, for example, the group of patients with HER2 targeted therapy. In some cases, potentially CDK4/6 inhibitors. They were not much represented in this group. But this is just to make the case that the CTC enumeration may be an important reading, together with imaging, as we know, to improve the assessment and the impact of therapies in metastatic setting. So just to summarize this part, it's clear that the CTC enumeration, now 16 years from the first discovery, can be used for stratification of patient stage 4 and independent prognosis overall, independent of subtypes of therapy. This retrospective analysis add on the evidence that maybe even the predictive value is relevant. Early treatment monitor is predictive of overall survival in this case seems to be irrespective of therapy. Of course, we wait more data for the type of therapies to see how a specific therapy can actually change from positive to negative, have an impact on overall survival. But what this also calls for a CTC molecular analysis integration with cell-free DNA to better understand what CTC positive means and what is the best therapy, irrespective of chemotherapy or targeted therapy we can use in this group of patients. Remain unsolved questions. So with regard to the cDNA, CTC technology, this is not going to be a talk on technology, but just to remind everyone that in fact, we can do CTC selection and then CTC molecular characterization. And they can go simply from FISH, VGA, and copy number aberration, even on NGS, but you are limited by the number of cells that you collect. So that's why it is very important to try to integrate cell-free DNA. They appear to be easy now and clinically available with NGS technology and digital PCR. So how do you use the cell-free DNA in evaluation of breast cancer? There are different time points, and of course, there are a lot of studies done in the metastatic disease and the area of disease monitoring, where we can spend most of our talk. But there is also an area we touched briefly on the area of localized disease and MRD. Appear to be an increasing interest area of research at this point, not necessarily immediate clinical application. What can you do with cell-free DNA in advanced disease? Well, you can detect actionable mutations. One of the most important and also most common mutations in metastatic breast cancer, particularly at this point in hormone receptor positive, but also in triple negative PI3K mutations. These mutations are present in approximately 30% of breast cancer patients, as I say, across the different subtypes, but most common in hormone receptor positive disease. The most common variants, hotspots on exon 21, H1047R, and E542K. On exon 10, and this accounts, the second one is the less common, but it's also represented. Essentially look at the kinase domain and the elegant domain. And as we know, we have now an approved, FDA-approved drug together with the companion diagnostic, alpelisib. This is for PI3K mutated hormone receptor positive patients. And this is the result of the SOLAR-1 study. They randomized patients that were PI3K mutated or non-mutated to two different cohort of treatments, one with alpelisib or fulvestrant, the other with palbociclib, with fulvestrant and placebo. And these two patients, the primary endpoint was the progression-free survival in the PI3K mutated. These were based on tissue, but there were also cell-free DNA collected. And obviously, this was also an important finding. There are a number of research that derive from this. First of all, just to remind everyone that this study was positive all in a PI3K mutated cancer. There were a group of patients that received CDK4/6 previously. So now this is becoming more and more used in the post-CDK area. But important, as I said, there was a PI3K mutant determined by cell-free DNA that showed that, in fact, at the time of the initiation of treatment, if you have this mutation, you may actually get a significant benefit. There was a San Antonio follow-up with regard to specifically the cell-free DNA determined both by NGS from Foundation, CDX, and obviously also digital PCR. It was clear this patient had, in a larger analysis, detection of PI3K mutated would have benefit from the treatment. There was not a complete overlap between the tissue and the cell-free DNA. So this is a word of caution. Sometimes we have to use both in order to assess the presence of mutation. Of course, this use in the clinic of cell-free DNA NGS now brings up the idea that we can describe the genomic landscape of metastatic breast cancer in a much easier way without having to access biopsy on multiple sites of metastasis in the same patients. So we had a large database of patients that have been receiving cell-free DNA analysis for clinical use with Guardant 360. And this was the first cohort of 255 patients, with some of them with multiple samples. And we just asked the questions, which is the number of allele frequency for major draw, the number of genes, which are the most common genes, and what we see in the different subtypes. And you start to see the distribution of the landscape of mutations that have been described in alteration for disease subtypes. Of course, in HER2 subtype, you have HER2 amplification. You may have a small fraction of HER2 PI3K mutations. Triple negative P53 is the dominant. And this is the distribution of the three most common, possibly actionable RB2 mutations present in the ER positive, ESR1, large component, all in hormone receptor positive, particularly exposed to AI, and PI3K mutations. We started also to play with this data and see how this CYP3 DNA allele frequency can be used as a measure of tumor burden, particularly with the distribution of sites. So you see there is an increase in the allele frequency, and there is an increased burden of disease as measured by the number of sites, and also the number of alterations seems to be increasing when there is more tumor burden. And this is what the initial essentially assessment of cell-free DNA, not only as an actionable tool, but also as a way to monitor disease. And we'll get back to this data later. At the last San Antonio, we also present together with MGH an interesting data set was looking at the genomic landscape of metastatic breast cancer when you don't know the subtypes. This is the database from Guardian, and try to develop an algorithm to identify subtypes. And so these are de-identified genomic data from stage 4 breast cancer. These were clinical samples that were submitted for next generation sequence, large data set. And obviously this is, everybody should be familiar with the 72 genes and then quote and control genes that are part of the Guardian database. So you see the predicted hormone receptor positive in more than 4,800 patients, predicted F2 in 489, of course, a smaller cohort, and predicted triple negative in 1,500. This also reflects necessarily the need and the use in the clinic of cell-free DNA. You are more need for an hormone receptor positive and a triple negative eventually that you have in HER2-positive disease. And so when you look at the comparison between the genes that are being identified in primary tumor with the TCGA versus the Guardian, you start to see the difference. PI3K essentially doesn't change much. So it can be a marker resistant in a specific subset, but it's a founder mutation. It's going to be present there. There is a little bit, obviously, a large increase in ESR mutation. That is an acquired mutation. We'll spend a little bit more time on that. And other mutations that appear to be driven by treatment, RB1, probably for the exposure to CDK4/6, RB2, endocrine therapy resistant as well. So you can start using this algorithm to really predict what type of patient you're dealing with, what type of therapy they've been exposed to, and maybe design the next type of therapy. So of course, cell-free DNA, if it's useful for monitor, can also identify treatment resistance and also helps for molecular response to treatment. One of the most common mutations that we see in breast cancer, particularly in hormone receptor positive, are ESR genomic abnormality and particular point mutations. Most recently, we have been seeing also fusions, but this is really very rare. And the genomic alterations may be obviously clearly in metastatic disease, and in patient resistant, you may have even polyclonal mutations in ESR, and we'll see a few examples. So these mutations, the most common Y53S and D538G, are essentially activated, and there is a constitutional activation irrespective of the ligand in this particular location of the receptors. Interesting to notice that the last San Antonio were also data in suggesting that these mutations are associated with the development of clusters and drive really the metastatic process. So it's much more important than simply think that this is going to be a resistant marker to a specific endocrine therapy. We just need to change the treatment. So the Paloma tree gave us the opportunity to really investigate some of these resistant mechanisms. Just a reminder, the Paloma tree is a phase 3 study, randomization 2-to-1, with patients that have been exposed or progressed on endocrine therapy, and they were stratified based on the sensitivity to prior endocrine therapy. Visceral metastasis, no, the randomization was obviously Ibrance in combination with fulvestrant plus or minus LRH blockage in premenopausal patients versus the placebo combination. We know that this patient had an improved progression-free survival, and then we had a baseline collection of plasma to look at ESR and PI3K. And as you can see in this particular analysis, the baseline ESR mutation, or so-called positive, doesn't seem to have an impact on overall impact on the treatment. But clearly, these patients are all receiving fulvestrant, and they were not priorly exposed to fulvestrant. So they're receiving the optimal, what we consider the optimal endocrine agent for ESR mutant. The other question, I think probably most important, is what happens at the end of treatment? What type of mutation you see acquired when you have a clear evidence of progression? And this was the paper that Ben Leary from the Turner group was a publication in Cancer Discovery in 2018, was presented at the ACR meeting. You see there's an increase in ESR mutations in spite of the fact that this patient received the best endocrine agent. There is a progression, and there is also new variants of ESR and polyclonal mutation. There is also an increase in PI3K mutation, suggesting that these are the two major mechanisms of resistance to the combination of fulvestrant and palbociclib, but also important PI3 kinases agents, in this case, have been suggested as a possible therapy when you have an increase in the persistence of PI3K mutation. There is a small fraction of RB2 mutation, as mentioned prior, as a possible resistance to endocrine therapy. Clearly, you see RB mutation also appearing in these patients. So this is more specific. I look at the variants of ESR mutant that are present in this patient at the end of treatment. And this particular variant, the one that we just mentioned, Y537, significant increase, and this may be a specific marker resistant for fulvestrant. Obviously, this is an area of drug development with regard to SERT, the target ESR mutant, and they will be eventually integrated with the CDK4/6 or alpelisib as a next therapy for patients with these specific mutations. And this is once again to look at the different variants, obviously the possible hypothesis how these mutations evolve over time in the context of endocrine resistant as a complex mechanism to a combination regimen. So we went back to our database and now asked the question if the serial circulating cfDNA can actually help to understand resistance. And we asked specific questions related to the tumor burden and to molecular evolution. These are, again, the 255 patients. We want to identify patients that had cfDNA longitudinally collected, so they had data of progression 1 and progression 2. And of course, the number of patients gets smaller and smaller. And again, with this patient analyzed with Guardian 360. And you see on the left, on the right side, the difference in median allele frequency. When there is a progression, the allele frequency increase and the number of mutation increase. And the smaller number of patients that we had the second time point seems to have the same trend. Then we look at the baseline and the progression one. What are the most common alterations that progress? And you can see here that p53 is very red. So you have a progression of p53, you have ESR mutants, and a few others. Clearly, progression disease may mean different things. Sometimes you may have just a minimal increase in allele frequency, or you can have more mutations. So disease burden or increase in genomic abnormality, where p53 remains the most common. NRB1 is also associated with specific type of mutation. This brings up how we can predict mutations driven site of recurrence in this patient with metastatic disease. And this was the question that we asked when we integrated data now with CTCs, the organ tropism of metastatic breast cancer using a combination of liquid biopsy tools. So we combine essentially the allele frequency of the different genes that we have identified with the CTCs. You see the different allele frequency with regard to the specific site of recurrence on the left side, and here now the CTC with regard with the allele frequency together with the site of recurrence. And you have a picture of this type where you look at the lymph nodes, the liver, the bone. You see that in CTCs are more important in bone, for example, primarily driven, and also lymph nodes. But you have, as mentioned before, the liver metastasis where there is ESR mutations in specific subtypes, etc. So you can start playing using actually artificial intelligence, how you can direct your imaging, your particular target therapy, your intervention, sometimes even local therapy, for patients that have a specific mutation or specific combination of liquid biopsy tools. So the other area, as I mentioned, that is just developing right now is the MRD detection. There have been a number of studies looking at different technologies. Of course, they are a matter of sensitivity. You cannot use the current NGS panels that use a metastatic disease for localized disease for MRD detection. But this is a question that is very important now that there are new drugs and more effective drugs coming in this area, talking about triple negative with, of course, checkpoint inhibitors, and maybe abemaciclib will be approved for high-risk metastatic early breast cancer. So this is a paper that was published in JAMA Oncology just last summer. A look at the cell-free DNA these patients had in the context of a clinical trial collection of blood for CTC and cell-free DNA measured as a positive, negative. And you can see that cell-free DNA negative patients did not have a recurrence, whereas ctDNA positive had an increased risk of recurrence. And of course, it was very early to figure out exactly what the impact on survival was. And then you combine together the CTC detection, different technology, not the cell search. And obviously, you can see that the worst patient are the CTC positive and cell-free DNA positive compared to the CTC negative and cell-free DNA negative. So I will imagine that in the future, instead of basing our adjuvant intervention after neoadjuvant, for example, to everybody based on subtypes give a specific therapy, we will be able to differentiate which patients really need a more targeted therapy or more prolonged adjuvant treatment for cleaning of this molecular recurrence, I would say, versus just an observation in order to save resources, of course, be very appropriate with regard to toxicity management of these patients. So just to conclude, I hope I convinced you that metastatic breast cancer is not only clinical, but also molecular heterogeneous. NGS helps us to identify subtype-specific genomic abnormality that can be useful for treatment. It's clear that CTC enumeration has a value in prognostication, and so therefore can stratify patients stage 4 aggressive and stage 4 indolent, and appear that has a value also in monitor as a predictive value. There's a clonal evolution that you can really understand and discover when you use NGS liquid biopsy. And there are very clearly actionable mutations, PHEK, of course, with the alpelisib, but also ESR mutation and 2 mutations. And this has the advantage of real-time detection and monitor of genomic alteration, as well as measure tumor burden. I would like to see cell-free DNA be included even in the NCCN guidelines, because this you can now practice oncology, breast oncology, without having cell-free DNA testing in metastatic disease. It appears that this technology, a more sensitive technology, can be used also for high-risk early breast cancer to detect minimal residual disease. And I'm really convinced that this combination of liquid biopsy technology changing the assessment and long-term impact of this patient. Too many people to really thank. Of course, the MD Anderson investigator, Herbert Fitchie, Jim Rubin. Manny, we start working on stem cells, as you know, as a component of CTC, still ongoing. Hopefully, we will really make a major impact in this area. The breast medical oncologist. I work with several companies, continue to collaborate, and of course in my lab now at Northwestern, as junior investigators that are very enthusiastic about liquid biopsy. There is no shortage of hands of ideas, and I think this is much different what it was years ago. And I don't want to leave without remembering the SLB and the leadership, and of course invite you to join the SLB so that we are all together pushing this field of research and innovation. Thank you.
Thanks, Massimo. It's a spectacular presentation. I have 2 questions. One, there is from Neha Mithilesh. Is asking, are there any specific tumor marker which can help in the case of early stage breast cancer diagnosis?
Early stage breast cancer diagnosis. Are you talking about early detection, or you're talking about
early detection and early stage?
Yeah, well, early detection, as you know, another area of liquid biopsies, GRAIL technology, is trying to get into the space of early detection in patient high risk of developing cancer. It is a small panel, is a very sensitive technology. And I think they have shown that in breast cancer, certainly can detect early detection of triple negative is possible, less likely they're going to happen in ER-positive disease. For other tumor types, has been obviously more possible. We're talking about colorectal cancer and non-small cell lung cancer. I think the future is to use this as a way to really go in high-risk populations. We know that, for example, doing a CT imaging in a large scale for smokers is essentially impossible. So the future will be early detection in high-risk population just using blood tests.
Thank you. I just have one question. Is that, like, from the day you started from a CTC, now, as you said, really, not only you played a big role in doing the game changing this CTC or liquid biopsy area, but today the technology is in a different plane. So have you guys looked at like characterizing the mutation in a circulating tumor cells and also in a ctDNA to see how well the ctDNA represents CTC or CTC represents a ctDNA on the same patient?
Yeah, that's a good question. We did ERS mutations a while ago in the CTCs. At this point, we're really trying to address the CTC mutation in the context of patients that had this garden test, so we know exactly which mutation. And one of the very easy ESR and PI3K mutations. With regard to the isolation of CTC, depends on the use. I think many times we talk about the cell search as the best standard FDA approved for clinical use. We also use other systems for other purpose. For example, we are studying clusters, and we use filtration systems to study the clusters. It's the best way to isolate the clusters and then go into specific biomarkers. We use the parsortics for other purposes. Eventually, if you want to take cells that are alive or grow, or try to develop organoids. So I think there are several technology of their advantages over the cell search when you go more in the research questions.
Mani, I have a question, if I can ask.
Please.
Yes. So Massimo, excellent talk and excellent work. And I have been following your work for a long time. There's a paper you published in 2014 in PNS. And it was about the tumor-associated macrophages. And I actually got fascinated. And I keep asking the same, that why we need to follow CTCs or ctDNA? Why not macrophages or neutrophils? So I would be very happy to understand that why not clinically we could use macrophages or neutrophils even in terms of anti-cancer drug response. And why not, we are investing our time as a liquid biopsy researcher in any other cells other than CTCs or ctDNA?
No, you're absolutely right. I think that paper was in fact conducted using a filtration system. And there's been a follow-up. We also present AACR San Antonio. We're submitting a paper from that. As you know, the camel size is important indication of probably there is some exhaustion of the innate immunity in these patients. This test has been used in the context of clinical trial indicating treatment resistance, maybe in a stronger fashion than CTC do. So I totally agree that maybe at least we can start to integrate the microenvironment, the innate immunity, these cells, especially now that we have, checkpoint inhibitor and others. It appears from early studies that maybe the resistant checkpoint inhibitors are driven by also or identified by the presence of these large camels in the peripheral blood. So no matter what you do, you will never have a response to checkpoint inhibitors when you have this failure of the innate immunity with these large camels. So it's fascinating. I say one of the investigators in our lab is also looking at these dual positive cells. CD45 positive, cytokeratin positive cells. What are they? We're trying to identify these are few cells, or what's the component of the CD45 and maybe monocytes to these cells. Yeah. So there is a lot going on when you look at the circulation of cells, whatever type of cells in the blood.
Okay, thank you.
There's a question from Rick. Rick, do you want to ask? Do you want me to ask?
Sure, I can ask if that's okay. Thank you for a wonderful talk and so much wonderful work over so much time. But you'd mentioned, I think, in the either ctDNA or the CTC that the PIK3CA mutation wasn't always matching the tumor.
Yeah.
And I just wondered whether one proved to be more closely linked to the CDK4/6 inhibitor response.
Well, so as I said, at San Antonio, there was this presentation. There was a follow-up of the work that they've done with cfDNA, and there was not completely overlap. When they look at there was a different distribution of allele frequency of the PI3K on cfDNA compared to the tissue positive, tissue negative. And there's a group of patients didn't match. As you know, maybe some tumors are not shedding. There is a possibility. I don't know exactly, when is, what type of biopsy they had. Some patients may have lymph nodal biopsy, maybe there is less shedding. So in that case, you may not detect PI3K. Just to say, like you do, for example, in non-small cell lung cancer, in some cases we should use this reflex, approach. Do you have this mutation or not? Do you verify that it's in the tissue or in the blood? But as you see from the Guardian test, there's a large proportion of patients with PI3K mutation. It's very unlikely that you're going to miss a cell-free DNA detection of PI3K mutation in this patient, particularly when you have more than one time point. I think that's the advantage. You can repeat a blood test multiple times. So you can figure out very early on if this patient is not shedding, the tumor is not shedding or not. In that case, of course, you have a limitation, but that happens very rarely. I mean, we have more than 95% of the patient with stage 4 where you can find mutations in the metastatic setting with an NGS panel.
Thank you.
Thank you.
That's
I think
fantastic.
in the interest of time, probably there is a 2 follow-up question. Massimo, if you can respond to that and the chat itself, and I'll pass the mic to Prashant. And thank you, Massimo, for a wonderful presentation and the discussion. Thank you.
Thank you, everyone. Enjoy the meeting. Great to participate.
Thank you.
Thank you,
very much.
Massimo. Prashant, I'll just take 1 second. I have seen delegates join in, so I would just like to acknowledge all that have joined in. And to start with Dr. Rick Thompson, Dr. Shamla Maheshwaran, Dr. Kumar Prabhash, Dr. Govind Babu, sir, Dr. Nanda Rajneesh, Dr. Ullas Batra, Dr. Nipun Sandhir, and Dr. Darshana Patil. All these speakers and distinguished delegates have joined in. And thank you all for gracing us with your presence and your talks. And Prashant, please take over.
So we'll just move for the next speaker. And it's my great pleasure to introduce Dr. Govind Babu. Dr. Govind Babu is a very renowned cancer specialist in India. And I would say that he has more than 25 years of experience. He is a professor of medical oncology in Kidwai Cancer Institute of Oncology, and he recently moved to SCG, Curie Center of Oncology in Bangalore. He received training in Dana-Farber MD Anderson Center in the USA. He has more than 60 national and international publications in his credit. He is a recipient of many national and international awards. He has been part of many national and international research committee, including clinical trials in oncology. So I will not delay much, and I would welcome Dr. Govind Babu to deliver the talk on clinical utility of liquid biopsy in advanced breast cancer.
Thank you, Prashant, for having me on this wonderful meeting. Actually, more than me sharing my knowledge, it is me learning from all of you. And I think the talk that Dr. Massimo gave was fantastic. I happened to meet him a couple of months ago in Bangalore, in Delhi, actually, when he had come. And we did discuss the work that we've been doing. And what he presented today is really fantastic. So since I would consider him the father of CTC, some of the papers I'm going to quote is his papers, which he has already quoted. So let me start off the role in breast cancer management of liquid biopsy. And this is welcome to you from Bangalore. This is one of our iconic state central libraries. So I thought I'll just share this picture with you. Today, we know cancer is a genetic problem, and it is associated with a lot of mutations. So this is just to give you a brief of that. And as Prashant told you earlier, what we're trying to do is personalized therapy to give the right patient the right drug at the right time so that we give the best to him or her and avoid the toxicity. So all our efforts has been in this direction. So liquid biopsy, this is just to tell you how we define it, what are the ways that it can be used. And as Dr. Massimo actually showed you extensively about how this is being used. So I'll just go through rapidly. Today, we know that as tumors grow, there is an angiogenic switch. And by which we mean that these tumors secrete various substances to produce neovasculature. One of the most important of those is the vascular endothelial growth factor. And this neovascularization is invariably leaky. And that's what is the advantage we take off to study the various aspects in liquid biopsy. So this is just to tell you what is the difference between liquid and target tissue biopsy. And Dr. Massimo has very nicely told you the same things earlier. So let me start with CTCs for you. Just to give you a broad idea of CTCs, a billion RBCs, but very few CTCs. It is like looking for a needle in a haystack. But with all the technologies that people in the lab have actually put forward and helped us, this has become this, that the needle is huge now and the haystack is small, and therefore we are able to get all these CTCs and study them. So again, in 2013, there were over 400 registered clinical trials which use CTCs as biomarkers. And as you know, the first paper was by Dr. Cristofanelli in NEGM 2004, which everybody have been talking about. We also had in colorectal and prostate. But for today, we're talking about breast cancer. So this is a paper which was published in 2012, which is a meta-analysis of over 49 studies. And this actually looked at the progression-free survival in those patients who are CTC negative or positive, and overall survival. And again, just to tell you that this was shown to be a very good indicator for the outcomes in your patients. So let me again touch upon a little bit of work that we have done. And as you can see here, this was a work we did as looking at CTCs as predictors of response. And this was a collaborative work between my hospital at LIQUIDBIO, the Indian Institute of Science, and Dr. Prashant's lab. And these two are my PG fellows who actually worked hard on this paper. So this was the workflow that we collected 10 ml of blood. And what we did was we actually cultured these CTCs in these micro-agar wells. And we looked at the cluster formation. The culturing was done at 1 week. And that is when the readout was done. And I'm sure Prashant will talk more in detail, so I don't want to take away his thunder. So I'll just tell you how we identified these CTC clusters as shown here. CK positive and CD45 were the two markers that we used. And I will just show you two patient examples which actually showed us that we can actually serially follow these patients and document whether they're responding or not. And this is one of our first patients of triple negative breast cancer who we looked at the CTCs at baseline. Just to tell you that we looked at these clusters and classified them as tight clusters or loose clusters. And tight clusters is what we thought is an indicator for non-responsiveness to therapy. And if you see these bars here, the vertical bars, the orange part is representing the fraction of tight clusters. So this is a patient of triple negative breast cancer who continued to have response. And at 8th week, when we assessed, the number of tight clusters were very similar. And as you can see in the scans here, the response is continuing. So we were able to show that the correlation of clusters was in fact directly proportional to the response that was seen. So this is the other patient where there was no response and there was a progression. And again, we found that the number of tight clusters at week 12 showed that it was increased. And this was correlated with the imaging that again showed an increase in the disease. So these are just two examples. We had a cohort of about 50 patients. And this is just two examples I showed you, one for showing continued response and one for showing resistance. So we actually did on two cohorts, one was lung cancer and one was breast cancer. And this is just to show you the survival curves. And this is to show you that those patients who had very loose or no clusters are the ones who did very well, whereas those patients who had tight clusters or very tight clusters, their survival was very, very low. So I think this is just to show you that even in this small cohort, we were able to show a correlation of progression-free survival and overall survival with the cluster characterization that we were able to achieve in these patients. And we published this in scientific reports in 2018. Again, this is one of the very recent papers I came across to look at efficacy of circulating tumor cell count driven versus clinician first-line therapy choice in hormone receptor positive HER2 negative metastatic breast cancer called the STIC-CTC randomized clinical trial. So what they actually did was they had this large cohort whom they randomized and looked at the CTCs and decided on the clinical parameters and saw how these patients were doing. So this is looking at progression-free survival for the standard arm and when it was CTC driven. As you can see here, the patients who were CTC driven therapy were doing better, and similarly in terms of overall survival as well. So this is again correlating clinical low parameters, CTC low, showing you that they're very similar in their outcomes in PFS. And if you look at the group that had clinically high parameters and CTC high, you can see that again, there was a correlation of these two. So if they had clinical high parameters or high risk factors and CTCs were high, they were doing badly or very similar. Whereas if they were clinically high risk factors, CTC low, you can see that CTC seemed to be a much better predictor as compared to clinical parameters. And if the clinical was low and the CTC was high, again, you can see that there is a very nice correlation to this parameter of CTC. So this study concluded that this results of this trial demonstrate the reliability and clinical utility of CTC count to guide the choice between single agent endocrine therapy and chemotherapy as a first-line treatment of hormone receptor positive or B2 negative metastatic breast cancer. And for me, why is this important? Because for early breast cancer, we already have a tool like the Oncotype DX, but for metastatic breast cancer, we don't have anything. And this seems to be a wonderful tool for me as a clinician to fall back upon to see how best we can treat these patients. So with that, let me go on to ctDNA. And this is just the historical perspective of how we have come across and where we are today. And of course, the terminologies are varying. And to remember is that cell-free DNA is pretty abundant, 25 nanograms per ml. And that's an important thing for us to know. So for a long time, we've been looking at various cancers, be it breast, lung, or colorectal, as a picture like this. I'm sure you can recognize Mona Lisa here. But if you actually zoom in, it's a collage of different pictures. And today, with these molecular testing that we're doing, we're soon realizing that all these tumors are not just one, but a collage of different tumors put together, which are genetically so heterogeneous, and therefore we need to look at them differently. The classical things for liquid biopsy, the poster boy has been non-small cell lung cancer. So this is just to tell you how we have evolved. And this is very important. We've not progressed so far in breast cancer today, but we are making progress. So I'll demonstrate this to you with a case. This is a premenopausal lady with good performance status. She has a left breast mass, left axillary mass, stage 4B N2 MX, and the scans did not show any metastasis then. Then we did these baseline scans. As you can see here, these are the CT scans. Again, the baseline scans and the bone scan also showed multiple bone disease. So when we are treating metastatic, which has been there for a long time, which we generally follow, the visceral crisis present or not. So this therapy is recommended in this group of patients, except in the presence of rapidly progressive disease. So at this time, again, we were running this trial called Mona Lisa. And this patient agreed to be on this trial, and she was randomized into the study, and she fell into this group who got the CDK4/6 inhibitor, and this is all the drugs that she got. And why did she enroll her into a clinical trial? Because as most guidelines, including NCCN guidelines, tell us that the best option for any patient is to be enrolled in a clinical trial. And fair enough, this paper got published in Lancet Oncology, and I also happen to be an author here. And we were happy that we were able to enroll this patient in our clinical trial. So this is the pre-treatment scan. This is the post-treatment scan. As you can see, she's done well. And she did well for some time, but then she came back again with the symptoms. And when we saw, she had mild progression in the bones. So we today know that hormone manipulation is very, very important, but with subsequent lines of therapy that we give, there is going to be an incremental decrement of the responses that we see. And we are always trying to see why these resistant mechanisms occur. And as Dr. Massimo showed us so nicely, how we are able to detect these resistant patterns. So when this patient came back to us, these are the choices that we had. So my ancestors would laugh at these choices because, of course, we will look at genomic testing today because that is the in thing to do. And this patient was a PIK3 mutant, and we had to shift her to alpelisib. And as Dr. Massimo showed you, this was based on the SOLAR-1 study, which actually looked at the PIK3 mutations in the ctDNA and the tumor tissue as well. And this is, again, you have seen this slide before, showing you that the advantage of using alpelisib when PI3CK mutation is present. So this is another paper which I just thought I should share with you. Liquid biopsy assay could guide treatment for metastatic breast cancer. And as you know what liquid biopsy today is, and Dr. Jeff Ross concluded that this liquid biopsy could be done because we could avoid tissue biopsy that could be costly, painful, and possibly dangerous. And therefore, with all this, we're able to now look at resistance mechanism to one of the most recently introduced drugs, that is the CDK4/6 inhibitors, and we could look at the resistance mechanism and thereby target therapy for them. This is one of the very recent papers I thought I must share. This is looking at genome-wide cell-free DNA mutation integration that enables ultra-sensitive cancer monitoring. And this is a wonderful paper. I'll just show you some pictures. For lack of time, I won't be able to discuss these with you. And if you have a chance, I would definitely recommend all of you to go through this paper. And what this concluded was that liquid biopsy clinical application is likely to be the systemic treatment of patients with ctDNA relapse, a term we introduced for ctDNA detection prior to imaging detected relapse after curative intent therapy for early stage disease. And Dr. Massimo also spoke about this, that how we could detect these mutations early on with a liquid biopsy and tailor our therapy. So to conclude on the talk of liquid biopsy in breast cancer today, slowly but steadily making inroads into the management of breast cancer, and this will only get better. As you have heard from Dr. Massimo, who has extensively shown you the work going on and the work that he's going to present soon. With that, I will stop and thank you very much.
So thank you, Dr. Govind Babu. Excellent talk. And I'm really glad that you have highlighted some of the work which we have done together. So there are many questions, and I will start with a question which is very clinical relevant. And I could see that there's a question, somebody is asking that using liquid biopsy does not poses any risk. So the question is that if you use the liquid biopsy, if the patient is on the risk.
I don't think there is any question of risk. In fact, we are trying to do a liquid biopsy to avoid the risk of a tissue biopsy. So I think this is one of the safest interventions that you can do. And as you mentioned, liquid biopsy is not just blood. It could be saliva, it could be urine, any body secretion. So there, in fact, others are not invasive at all. So I don't think it carries any risk.
Yeah. There's another question from Dr. Richa Chauhan. She's asking about how frequently is CTC recommended in metastatic breast cancer patient?
As of now, it is still not for routine clinical use. So I don't think you should. It's still a long way to come into routine clinical use because of the problems of detecting the CTC itself, the interpretation. So I don't think you should use it for routine clinical practice.
Excellent. So there's another question that how deeply you have characterized the CTCs on the agar itself.
Oh, we didn't characterize CTCs on the agar. I think, Prashant, you're the best person to answer this.
Yeah. So we have characterized the CTCs definitely, and the characterization is based on different molecularly. So what you do that you just isolate those CTCs, and then you just stain with different markers. And we have done almost 200 different markers. So we have done very deep characterization of those cells. And for us to claim that the cells which we are claiming that CTCs, tumor cells, there are two ways. Either you take these cells and put it in the mice and show that it can make the tumor. And the other way is that you can grow these cells and make the tumorous sphere. And we have done this assay where we could culture these cells further, and it shows a very wonderful solid tumorous sphere formation. And this is another way you can show that the tumor cells which you are growing in the plate has the tumor property. So I would just go another question. I would just, there's a question about, again, using liquid biopsy, could you recommend the patient if there's any hazard with the health?
I think we've answered that question.
Yeah.
Can I take this question?
Yeah, please.
So definitely there is a hazard to the interventional radiologist. There is a hazard to the, the interventional pulmonologist, because they will run out of business. That's the only hazard that I can think about.
No, we'll find more work for them. No worry.
Okay, there's a question in terms of treatment with the PIK3 inhibitor. Do patient with PTEN deletions also responded?
No, I don't think they looked at PTEN. This was specifically for PIK3 mutation. So
Yeah,
all the patients who had PIK3 mutation.
Can I also take it again? I think in the trial, solar and popular solar trial, they took only patients who had a PIK3 mutation.
Yes,
Alpelisib
PIK3 mutation. That's
only approved for PI3K mutant. So I don't think in clinical practice
That's
somebody
right.
would have given this medicine to them.
Yeah, that's right.
So do you find a few PIK3 wild type patient also responding?
Never tried.
No, I don't think so.
I'll take that one. Actually, PIK3 wild type, the responses were much lesser. The survival was as good as the regular population, because they were the regular population. So this is a drug that is only approved for PIK3CA mutants.
Absolutely, especially given the toxicity profile that this drug has, I don't think we will ever try it out on a patient who does not have a mutation.
Okay, so we will just conclude here. So thank you, Dr. Govind Babu, for excellent talk. And
Thank you, Prashant.
I'll just ask Dr. Sevanti to take over.
Thank you, Prashant. And sir, that was an amazing talk, and that gave me a sort of a preview of what you and Prashant have done together. And
thank you. Thank you.
Passion behind it. Yes, I've seen it another time, but this was a reminder. So that's wonderful.
Thank you.
And we have our my good friend here, Dr. Ullas Batra. And thank you, Ullas, for accepting to speak at this meeting. I'll just begin by saying Ullas needs no introduction. He is his own introduction, and he just did that. We all saw. That's who he is. And it's such a pleasure to have you here, Ullas. So Ullas is a star medical oncologist at Rajiv Gandhi Cancer Center in Delhi. He is the chief of thoracic oncology there, and he does many, many more things. I find him being a thought leader in oncology, not just in lung cancers, but in most of the solid tumors, just like he jumped in to chip in on the breast cancer question. So you cannot identify Ullas or limit him just to thoracic oncology. He's an amazing speaker. I have heard him and have been entertained, so much so that whenever I'm asked to either duel with him or speak next to him, that's the first thing I say I'm going to run away from. So we are going to witness Ullas in action, and he's done some specific work at his center and leading some efforts in liquid biopsy. This is one of his thought processes, one of his visions that he's pursuing. And the main reason to request him to speak at this meeting was mainly that he has a perspective of how things work in an Indian cancer center, and how liquid biopsy could be implemented or tested in our clinics today. So Ullas, please take over. Thank you.
Okay, thank you, Dr. Sevanti. And I'm sure everybody will realize after 15 minutes that all that you said was not right. And I'll tell you the reason why Dr. Sevanti said that. With that, we will talk about it later. Okay, so when I heard when I saw my talk and I read the talk about EGFR diagnosis and monitoring, my first reactions at my talk basically were Dr. Sevanti actually telling me, "Dekh beta, seedhi baat, no bakwas," because she knew I will go here and there. So she said, "Okay, fine. You're going to talk only about EGFR mutations, detection, and monitoring. That's it. Don't talk anything else." So I thought, okay, fine. I'll try, but don't expect much. Let me try about what I can do from there. So outline of my talk, as Dr. Sevanti has very rightly said, is you can have liquid biopsy in EGFR mutations at diagnosis. You can have them for monitoring. At diagnosis, they can be using NGS, or we can use a COBAS, TheraScreen, or a ddPCR platforms. In monitoring, you can have a dynamic longitudinal monitoring, and you can have resistance mutations. So again, just to simplify that, for diagnosis, if you want to not specifically look for EGFR, you want to look for EGFR, ALK, ROS, MET, you do a liquid biopsy NGS, which can be the Guardant, which can be the Foundation MET, which can be the Ion Torrent. If you're looking specifically for EGFR mutations, you look at the TheraScreen and the ddPCR and stuff like that. So let me talk about the NGS first. Now, this was a complete study which was there, which basically said, that you want to look at NGS using tissue biopsy and liquid biopsy. Look at this, 543 samples in the end, and the positive predictive value for EGFR, L858R, or del19, or exon 20 insertion was 98%, 98%, 100%. So if you don't know what you're looking at, do an NGS. You will probably get the EGFR mutations as early as possible. I've used this before. There's a difference between being complete and finished. I will talk to you about it later, about what is complete and what is finished. This was another study, the Spanish study, which was a SLIP study. Again, if you see the EGFR detection rate between liquid biopsy and tissue biopsy, that was close to around, that was almost similar, around 98% concordance basically was there. So you can detect EGFR mutations by the NGS technique. So if you don't know anything, use NGS. That's a liquid first approach. Now, if you want to, if you know what you are looking at, if you have already sent for EGFR and other things, if you want to look specifically for the EGFR mutations, you can actually use, you can actually use the TheraScreen or the ddPCR or the RT-PCR. And I'll tell you some data about it. Now, there are three platforms which you can use. That is, one is COBAS, one is TheraScreen, one is ddPCR for primary detection of EGFR mutations. Now, this was the first test, which was the COBAS test, which was approved in 2016. You can use both the solid tissue biopsy and the liquid biopsy. And there was a trial which was called as a FAST-TRACK-2 trial, which had to have a concordance between tumor and plasma. And if you can see over here, it has got a very high specificity of 96.5, meaning that if the COBAS test says it is positive, it is positive. However, the sensitivity is only 75%. So that was for COBAS. Now, fair enough. Somebody, molecular pathologist can come and tell us, fine, your EGFR mutation is there. But as we say, the proof of pudding is in eating. What happens if I treat a patient on the basis of only plasma EGFR report? So look at this, the PFS graph between the tissue and the liquid is almost equal, which is absolutely similar. So the destination is important sometimes, not only the journey. Whether you get it by liquid biopsy, whether you get by tissue biopsy, the answer is, if you have a EGFR mutation, if you treat them with oral TKIs, the results are going to be absolutely similar. That was about COBAS. Now, COBAS tests for 48 or I think 48 or 49 mutations. Now, there's another platform, which is the TheraScreen platform, which basically again detects for 29 mutations. Now, this is something which I have found out over the last 6 months or 12 months. TheraScreen will detect only 29 mutations. And again, it has got a very, very high sensitivity and specificity. The third one is ddPCR. So you can use either COBAS, you can use TheraScreen. COBAS uses 48 or 49. TheraScreen uses 29 EGFR mutations. ddPCR, you have to have one specific thing for a mutation, like you can only detect ddPCR for del19, L858R, or T790M. Again, a very high sensitivity and a specificity rate, but the sensitivity rate is around 86% and 69% for del19 and EGFR. That is something which is very, very important. So this was an article which came in Annals of Oncology about the liquid biopsy. Again, they took a real world study. Again, what they found out was that specificity was 99.8%. The concordance was 94.3%. Sensitivity was 65.7%. So my take on this is, if my COBAS test or TheraScreen test or my ddPCR test says it is positive, it is positive. If it is negative, definitely go back and do the tissue biopsy after that. Now, I will give you a real-time example about what we did with the patient. Now, this patient came to us with a massive pleural effusion with an ICD from outside. He had some lymph nodes, a biopsy could not be done from there. And this is what the final PET CT scan actually reported as. The pleural fluid cytology was negative for malignant cells. And we tried the left side, the right side. We actually tried to induce pneumothorax into him and then do a thoracoscopic biopsy. Absolutely negative. Finally, with great problem we got, if you read over here, they said, a tiny fragment of tissue with scant atypical cell clusters, and it came as negative for P40, positive for TTF1, and it came as adenocarcinoma, inadequate for further biomarker testing. If you can see over here, what I did after that, I pleaded with my interventional radiologist, I pleaded with my pulmonologist, I pleaded with my pathologist, do something about this, give me a diagnosis. And this is what they all said, no, we cannot do anything more. And that is what, when we got the liquid biopsy done for there at that time, this was the ddPCR. And here we found out that the del19 test was positive. And this was mine and the patient's reaction to the molecular pathologist. Huge loads of cases for them, because this patient has got oral medicines now for last 1.5 years, and the guy is doing absolutely fantastic. So we spoke about NGS. We spoke about liquid biopsy to detect primary EGFR mutations. Now, what about the resistant mutations? And we all have seen Money Heist in in Netflix, and that's one of my favorite series. For people who have not seen, please go ahead and see the Resistance Money Heist there. So there was an AURA3 study. So let's say somebody was started on first or second generation TKIs. Patient progresses, and you take osimertinib or chemotherapy depending upon the T790M mutation. If somebody has got a T790M mutation, the median PFS was 10.1 versus chemotherapy was 4.4. But the question is, how do you detect the EGFR mutations? They could be detected by plasma or by ddPCR. And this is one very important slide. The paired samples were present in 216 patients, and it did not make a difference if you detected. So if you had T790M in plasma, your response rate with osimertinib was 63%. Median PFS was 10 months. If you had in tumor, your response rate was 62%. Median PFS was 10 months. So it does not make a difference whether you have got EGFR T790M by either plasma or by tissue. You're absolutely okay with that. So it doesn't actually make a difference. So this was a statement from the IACLC in 2018, which basically said, now this I'm talking about resistance mechanism. And they basically said that if you have a patient who has got resistance to the first generation TKIs, do the liquid test first. Either COBAS or ddPCR is preferred. If you have a liquid biopsy which is positive, treat with osimertinib. If it is negative, go ahead and do a tissue biopsy after that. So which one of them is liquid biopsy and which of them is tissue biopsy? That depends upon whether I'm speaking in favor of tissue biopsy or not. But they are neck to neck, very, very close about. So the audience reaction at this time is, this is all old knowledge, is this really the best that liquid biopsy can do in a symposium of 4 hours on liquid biopsy? No, we can definitely do more better, and we can definitely go to the next level. Now, for the next 7 minutes, I will show you what more can we do. So we spoke about liquid biopsy for detection. We spoke about liquid biopsy for progression. Now, what happens in between those 10 to 12 months? So this is a study which was done, which was reported, I think, in Annals of Oncology, which basically said that people who lose EGFR mutation at 4 months did much better than people who did not lose their mutation. So the graph C is the people who did not lose the mutation, and graph A and B are the ones which are the people who have lost the EGFR mutation. And this can act as a potential predictive marker of how the things are going to be. This was a poster which was presented by Tata Memorial Group. I think Kumar will speak more about it. The red group was the one which was the people who lost their mutation at 3 to 5 months. And the blue group was the one which did not lose their mutation. Again, people who lose EGFR mutation at 3 to 5 months are the ones who do absolutely fantastic. Now, can we predict response to osimertinib? Now, we also know that we give osimertinib when you have T790M present. Now, what happens is if somebody loses T790M after generation of osimertinib, and some people do not lose. So, this was again a study which basically said that people who lose T790M mutation are a poor prognostic subgroup over there. And in fact, the worst survival was basically achieved. Best survival was achieved with people who had both T790 and C797S, and the worst survival was there people who lost T790M. So, liquid biopsy in EGFR mutant non-small cell lung cancer is not only about T790M detection. You can do it prior, you can do it later, you can do it at detection, you can do it later. So this is what a group said, that maybe people who lose their T790M earlier, combine them with a MET inhibitor or something. People who lose it later, maybe we can add chemotherapy also to it. It's a very provocative statement. So that were two more things which I showed you. Now this is something which is very close to my heart and which we have done around 10 to 12 people. This was a 75-year-old male which came with headache and diplopia. The PET CT scans showed lung mass only. MRI brain was done, which did not show any leptomeningeal enhancement. CSF was done, which had no atypical cells. The case was discussed in tumor board, and they said, this is nothing but a paraneoplastic syndrome. We are going to, give either surgery or radiation to them, and hopefully the patient will get okay. At that time, we took Mentos, and we had a Dimag ki batti jal gayi, and we got a. So this is a CSF report actually for cytology, which said that there was no atypical cells actually seen over there. We got a ddPCR for CSF, which again said del19 was present in the CSF. So a potential stage 2 patient became an actual stage 4 patient. The patient was tried on osimertinib. The patient is doing fantastically well. We have published a case series of around 9 patients from our group in which CSF was positive for ddPCR, where and we could actually give the patient osimertinib. And this is something that you don't see every day, but this is something which I believe we should do more often. In patients suspecting of leptomeningeal metastasis, maybe a CSF by liquid biopsy can actually help. However, please do not forget the tissue biopsy. We had a 50-year-old female, started on first-line TKIs, progressed. We gave, it was positive for T790M. We started on osimertinib. There was a florid progressive disease after 3 months, and the repeat biopsy was small cell lung cancer. So this lady has SCLC plus T790M, and this is basically which shows me, welcome back. Liquid biopsy is good, but tissue biopsy is definitely here to stay. So what about RGCI data? We all talk about Make in India and all. So this is something which is Dr. Sevanti said, and something very close to my heart also. So we had 160 patients who underwent biopsy. Our tissue genotyping was done for 160. Our ddPCR was done by 151, and COBAS also was done. All 114 people who underwent that. So 114 people underwent tissue biopsy, ddPCR, and COBAS. And the mutation rate which was picked up by tissue biopsy was 42%. With COBAS, it was 40%. With ddPCR, it was 30%. ddPCR picked up more T790M, but less deletion 19. COBAS was almost equivalent to what we picked up in tissue biopsy. Again, if you see the COBAS versus tissue genotyping, the sensitivity was 95.9 and the specificity was 97.2%. And we are using more and more of COBAS by liquid biopsy to start with. The tissue versus ddPCR, the sensitivity was 97.8, but the specificity was 79.4. We are working on getting this thing actually better. Dynamic monitoring by ddPCR, I showed you the Tata data. Now in our data also, people who have lost EGFR mutations, the median PFS was 8.8 months, but people who have not lost the EGFR mutation, it is 8.8 months. People who have lost the EGFR mutation, we are still the median PFS is not yet reached, and maybe in the next meeting I'll show you more data. Now this is the T790M data that we have. Again, I'll tell you, our T790M positivity rate is around 50%, and people who either get osimertinib based on either tissue or plasma, the PFS is by and large similar, 6.9 to 8 months. Yes, the number is a bit small, but then we get all sorts of osimertinibs also. So my conclusions, liquid biopsy is fast emerging as a viable tool in the management of non-small cell lung cancer, high concordance with tissue biopsy, established role in detection of primary EGFR mutation. It may be used in dynamic and longitudinal monitoring. So Dr. Sevanti, I did try my level best to make it interesting. And with this, please stay safe, keep the spirits high. I have got my vaccination. Even Mona Lisa has now got her vaccination. And I hope all of you stay safe, and I'll get back to the organizers. Thank you.
Thank you, Ullas. That was a stellar presentation. And as I had guessed, you did a fine job with EGFR, and you could have done with much, much more. That's just goes without saying. The reason to choose EGFR is I had seen your ISLB submission, and
I saw yours too.
Yes, I saw your data, and I knew that those slides may be ready, and Ullas will not say no. So thank you. This was amazing, and you know, the reason why this is so critical, and the reason why you were the best person to talk about this was because this is directly applicable. We struggle every day with this, and you know, how many of us have the knowledge of what are the nuances of testing EGFR? So I will just begin with a few questions that have come through. One of them were, do you practice longitudinal ctDNA testing in your lung cancer patients?
So
and
yes.
Which patient would you consider?
So yes, we are doing a research study. We have got around 35 patients now. We were going full stream, but then COVID struck and then people did not come. So that is why we took a break for around 6 to 7 months. And that is what I showed. We are using ddPCR, but there's some problem in getting the reagents from I think France. There was some problem, but we are again getting back to that. We've got 30 patients now. In fact, our data says that if you have more than 2 log reduction in the values of the ddPCR, you're actually doing much better over there.
Excellent, thank you. So Dr. Shamla Maheshwaran from Harvard, she asked, how did you determine the presence of SCLC in the patient you described? Was it from repeat metastatic biopsy?
Yes.
And she has a second question. My second question is whether T790M mutation and SCLC resistance phenotype observed in NSCLC patients receiving EGFR targeted therapy are mutually exclusive.
No, they are not. So we got a repeat biopsy done actually. And so we got a plasma biopsy, plasma liquid biopsy done, which came as positive for T790M. We put the patient onto osimertinib. She did not respond. We got a biopsy done, and that showed SCLC. There is, I think, 1.4% of people which do show, you know, small cell lung cancer plus T790M. So they're not mutually exclusive. It was a lesson learned the hard way, and I had egg on my face.
Excellent, thank you. Dr. Arun Kumar asks, please clarify the ddPCR kit used in the data.
So I will not be the right person to answer the ddPCR kit actually. I think I have talked to my molecular pathologist for that.
Sure, no worries. There, so Dr. Rick Thompson asked, these are very exciting results. Is it quite special for lung cancer in terms of ctDNA burden? How about head and neck or cutaneous squamous cell cancer that also have EGFR etiology? So do we do EGFR testing in head and neck or squamous cell cancer of the skin?
I think the issue there is you get EGFR amplification. Here you get EGFR mutations, and ddPCR can actually quantify those. So that's only specific for lung and not really there for head and neck right now. But we are doing a liquid biopsy NGS in immunotherapy, and we have got 18 patients right now. Because you know what happens in immunotherapy is that after 4 cycles, the report comes as IUPD. Now you don't know whether the patient is really responding or not. So we are doing a liquid biopsy NGS based technique to find out whether the values actually are going down or not. And the results seem to be very exciting. Hopefully in this ISCLC, we have got 18 patients till now. Statistical significance, we need 22. Hopefully next month we'll have 3-4 patients more in lung cancer only, and then we'll tell you the data.
Excellent. Thank you. Dr. Prashant asks, EGFR mutations are coming up in other cancers. As we do NGS, we see different alterations that could be targeted in other malignancies. And could we repurpose the EGFR TKIs like osimertinib or other TKIs in other cancers? Like if someone were to be found to have an EGFR mutation in bladder cancer, in an atypical type of breast cancer, would you be open to repurposing the EGFR TKIs?
So not in the first line. I think I lost you. Can you hear me?
Yes.
Okay, not in the first line, not in the second line in breast cancer, but probably second line onwards, I would be absolutely okay to target that, because first line I don't want to play around with the result, because a lot of results of Shiva trial and others have shown that you don't base your first line data on the base of NGS, but definitely second line onwards, why not?
That's fantastic.
Prashant, Dr. Govind Babu here. You were talking about EGFR targeting. In fact, from Cuba, there is some data on targeting EGFR with the monoclonal antibody called nimetuzumab.
Okay.
But we don't have extensive data on that other than from Cuba.
So I have just got a message from my molecular pathologist, Dr. Srinidhi. She says BioRad was the DDPCR kit.
Okay.
Thank you, Srinidhi, for bailing me out on this.
You got your answer live. And Parul Gupta asks, why do you prefer DDPCR over conventional method?
Okay, there is no, there's a very simple one. DDPCR came early. DDPCR was cheap at that time. We didn't have COBAS at that time, but now we have got COBAS. We are slowly, we are getting very much difficulty in getting DDPCR done because the reagents are not available. So, but I am very happy with the COBAS results right now. DDPCR will pick up only 3. COBAS actually picks up the atypical mutations and everything. So I'm very happy with the COBAS right now. But for T790M, the sensitivity of, so again, my take on this would be for any resident listening to this. If you want to see the primary EGFR mutation, COBAS is good. If you want to specifically look for T790M, DDPCR is better.
That's such an important point. I think the message that goes out here is, if you're doing an exploratory EGFR mutation testing, then you have to test a little broadly. But if you're looking for just one alteration, then DDPCR is good enough. So that was brilliant. Thank you, Ulas. As usual, you did a stellar job. Wouldn't have expected anything different. And thank you again for joining us. And I'll just take a moment.
Generous, Dr. Sevanthi. I don't think.
Well, thank you.
Thank you.
And I welcome Dr. Ram Prasad, who's joined in, and Dr. T. Raja sir for joining in as well. Welcome both of you, and over to Prashant for the next talk.
So our next speaker is Dr. Nanda Rajneesh. Dr. Nanda is an eminent surgeon endowed with rich and diverse experience, more than 22 years, a specialist in breast surgery and laparoscopic surgery. She's a member of Royal College of Surgery. She has performed more than 15,000 surgery. That is spectacular. She holds a position of associate professor in St. John's Medical College. And at present, she's a consultant, GI laparoscopic surgeon, oncosurgeon in Apollo Spectra. So Dr. Nanda, we welcome you, and we look forward to listen your talk on liquid biopsy and screening and management of breast cancer. Please unmute Dr. Nanda. Can you please unmute your microphone?
You need to unmute the microphone.
All right.
Yes, yes.
Yeah.
Yes, yes.
Yeah. Good evening, Dr. Prashant. I thank you for inviting me for this presentation. I'm going to talk on role of liquid biopsy in screening and management of breast cancer. Yes, it is one of the evolving methodology of screening and screening even patients with breast cancer during follow-ups. So I thought I will take everyone through evolution of breast cancer itself and how the factors that influence the breast cancer cells. Sorry, what's happening? My slides are not going. Okay. So worldwide,
Ma'am, you need to share the screen, ma'am.
is it? Okay.
Yeah, you need to share the screen once again. Yeah.
One second. Okay. Can you see now my?
Yeah, ma'am, the screen is visible. If you can open the presentation.
Yes.
Yes, ma'am.
So as we all know, the worldwide incidence of breast cancer is tremendously increasing. And it has, in India especially, it has even overtaken cervical cancer. So we want to see why this number of breast cancer patients are increasing. There must be a lot of influencing factors also increasing. So if I show you the list of risk factors on breast cancer itself, you see that there has been real increase in my clinical practice that I see, especially if I say a lot of women who come with the breast cancer are obese patients. And secondly, on of very often I'm seeing bacterial infection in a lot of women, and maybe going forward they will develop into breast cancer. And eating red meat is also increasing, and there are other influencing factors that are progressing to breast cancer. We do know breast cancer cell formation has a multifactorial influence, and it doesn't happen in one day. It is an evolution from the specialized cell formation to a typical cell formation, ductal carcinoma in situ, and malignancy. So during this process, our body also takes a major role in killing these cells. So when the cells die, there are certain circulating factors also getting into the circulation. So I like to take you through the development of the breast itself in different times with from proliferation to differentiation of the breast. So during this process, when the unspecialized cell formation happens during proliferation, then you see if the proliferation is very fast during puberty and sexual maturity, number of high risk cells are more, means there are more high risk cell, again numbers keep increasing, whereas during differentiation there is a protection to the breast for cancer cell formation. That is because if there is one high risk cell, it can multiply to only few cells, or it may not even multiply, or it might die because of the change in the hormone system during pregnancy and lactation itself. So the cancer cell formation, as I said before, it starts as an initiation of a mutated gene as an unspecialized cell. Then that initiation has to promote to during proliferation. If this promotion happens, number of cells become very high, and it progresses into mutation with many other influencing factors, and it becomes a malignant cells. So imagine the high risk cells are more, the carcinogens affecting these high risk cells to convert them into cancer cells also becomes very high. So coming to the role of liquid biopsy, we do know majority of the cancer therapy decisions are definitely based on histopathological molecular pattern itself, and it remains still true now, even today. So, but if we can get liquid biopsy, a promising approach in medical field itself, and it helps us in predicting, monitoring, and selection of the appropriate therapy also in these patients. So let us say I have patients coming very often. See, in my clinical practice, if I see 10 patients with a breast problem, only 1 or 2 would be breast cancer patients, remaining 7 or 8 would be non-cancer patients with many problems. But they also always have a fear of cancer. So it is good if I have a simple test than multiple radiological tests on these patients, like liquid biopsy. So liquid biopsy, we know that it also gives us a heterogeneous pattern of the breast cancer itself, which is very helpful during the treatment of breast cancer patients. So so how is the liquid biopsy different from breast cancer? Liquid biopsy different from the tissue biopsy? In breast, we need definitely more than 1 centimeter tissue to do a biopsy by the surgeon itself. Otherwise, we have to do ultrasound guided biopsy. So we have to depend on the radiologist to do ultrasound guided procedure. That is, imaging is required. Whereas liquid biopsy is very simple methodology. It takes very short time, and the cost can definitely improve, I think, over a period of time if we keep doing more tests. And it is compatible with the it can select heterogeneous pattern of cells also. So if you see here how breast cancer cells come into the circulation, I'd like to show you. One is in invasive duct carcinomas, the cell itself gets into the circulation, into the blood. The second thing is the cells that die can also produce a DNA, ctDNA, ctmRNA into the circulation. So this is another pattern. Third one, we just discussed about macrophages. Because there is an immune system also going to play a role to kill these cancer cells, the macrophages are known to take the or what do you call it? They swallow the mutated DNA also, and this mutated DNA can get transfected into the macrophage DNA, and these macrophages can circulate in the body and go and deposit in any parts of the body. This is called biological theory, where this is a reason, that is one of the reasons that is described for metastatic recurrence later in life. I would say, like you would have treated early breast cancers after 10 years, 15 years, even during the follow-ups, we can see recurrence in these patients. So this could be one of the reasons. That is transfection of the mutated DNA into macrophages, and they go and deposit in different parts of the body, and they're mostly inactive initially, and they can get activated anytime if a patient has persistent, again, high risk factors continuing in them. So circulating tumor cells are substantially rare in the blood of the patients in early breast cancers. We know that. So, but there are additional molecules that are present in the blood that are detached from the tumor cells itself, like ctRNA and ctDNA. Some nucleic acids and extravesical particles can be very helpful in detecting early breast cancers or maybe in screening. So there are certain studies which have shown in metastatic cancers a lot of circulating tumor cells, whereas in early breast cancer, about 55% of the circulating tumor cells. And they've also shown in certain genomic ctDNA studies also that it is giving a prompt and valuable prognostic information in cancer patients. This is one of the clinical trials which was done, which shows the green ball shows that more the number of patients that were included in the study, we had a better result. So it showed more significance of the circulating tumor cells and circulating DNA detection. Now, so patient and treatment selection for neoadjuvant therapy, it is very important. What has happened? Yes, we do have many other markers that are possible to give neoadjuvant chemotherapy, but circulating tumor cells can also help us in finding the heterogeneity and role of therapy in these patients. So there are certain pitfalls to study the circulating tumor cells in early breast cancers. One of them is most challenging is number of cells are very less. Circulating tumor cells detection is difficult. So to overcome that, we have come with a newer approach, little bit invasive approach, where we put a needle, a long needle, steel wire needle with a hydrogel functional tip coated with EPCAM antibody. So what this stays in the body, and blood keeps circulating over this needle, and whenever the circulating tumor cells attached to this, it gets sucked into the, so this is one of the representation it shows, and you may be able to get bigger number of circulating tumor cells to study. So overall, clinical application of liquid biopsy in breast cancer is in early diagnosis itself. In screening general population, there are very few studies which tell us the role of this in general population. And predicting recurrences, yes, in patients with breast cancers, we do follow up with normally PET scan if in advanced cancers, and in early breast cancers, in breast conservation studies, we either do MRI mammography or mammography, routine mammography. These are being a radiological investigations. If I can predict the recurrence with circulating tumor cells, it can be very good and amazing for us. And targeted treatment, like designing a personalized or targeted treatment, which it is well established in lung cancer, but we should see the role of it in breast cancers. And longitudinal monitoring, development of drug resistance, metastasis, and response to treatment can also be studied. But as such, in treatment protocol, circulating tumor cells may not play a big role, because right now tumor protocol is basically dependent on stage of the tumor, which is dependent again on the size of the tumor, number of lymph nodes, and spread of cancer to different parts of the body. But in treatment protocol, it may play some role in early breast cancers, because what happens, it is very difficult, especially in an Indian patients who come from a rural population. When the tumor is removed, why should I take chemotherapy? Especially in early breast cancer, you are conserving my breast. Why should I take chemotherapy? So if I can show circulating tumor cells to the patients, they may understand this better, that, I am showing circulating tumor cells, and there may be better feasibility of convincing them to take chemotherapy, I would say, in my clinical practice. Thank you. I end my presentation here.
Thank you, Dr. Nanda. So, excellent presentation. And you touch the basics of the breast development, and I think it would be really well taken by the students. So I have a very basic questions that, so in your practice, how many patients you routinely use for liquid biopsy, either based on ctDNA, or do you use any other circulating marker like HER2?
No, we don't do any circulating markers in my clinical practice, because most often what happens, because I'm a surgeon, so I deal with patients in early breast cancers and or after neoadjuvant chemotherapy. So most often this kind of management or whatever investigation that has to be done is taken care by medical oncologists in our country. So.
Okay, thank you, Dr. Nanda. So we will now move to the next speaker.
Thank you.
The team, can you please put the...
So it's Dr. Darshana Patil, Prashant. I'll just go ahead and introduce her.
Yeah, please, please.
So Dr. Darshana Patil is the medical director of Datar Cancer Genetics in Nashik, India. She's going to be talking about True Blood, a revolutionary non-invasive alternative to conventional tissue biopsy. She's a master's in molecular oncology from Spanish National Cancer Research Center and an MD in pathology from Coimbatore Medical College. Darshana has been pivotal in supporting our molecular oncology tumor board, as well as many previous questions with case management as we have navigated the precision oncology initiative at Kokilaben Hospital. Darshana, it's a pleasure to have you today, and we've given you a difficult topic, but this was so interesting that I really couldn't stay away. So thank you so much for taking up this opportunity and for joining us this evening. It's yours, the floor is yours now. Please go ahead.
Thank you, Dr. Sevanthi. I'll just share my screen. We can begin the presentation. Is my screen visible?
Yes, ma'am.
So thank you, Dr. Prashant, Dr. Sevanthi, for this wonderful meeting. And it's a pleasure to showcase the data on True Blood and how it can help in future for patients who are struggling with a tissue diagnosis, and the clinicians who do not have a conclusive result on a tissue biopsy, and how liquid biopsy can play a role in this cohort of patients. TrueBlood, it is a blood-based diagnostic triaging methodology developed at Datar Cancer Genetics. It utilizes circulating tumor cell ensembles to assist in establishing diagnosis of cancer, so that it can provide information where a tissue biopsy is not feasible, or for diagnostic triaging, or to select patients on priority for physical biopsy. So tissue biopsy is gold standard, as we have already discussed, for establishing cancer diagnosis. However, there might be certain issues to obtain tissue biopsy in certain patients, where because of the location of the tumor, it is located close to certain vital areas, or there are certain patient comorbidities which do not enable to us to get a physical tissue biopsy sample. And also in certain situations where a physical biopsy has already been attempted, there are some complications, and thus repeating an invasive procedure again becomes a challenge. Potential to offer a non-invasive, one sec, I'll just. Potential to offer a non-invasive solution in such clinical scenarios is absolutely very relevant. And in this situation, already a circulating tumor DNA or the enumeration of circulating tumor cells has been already attempted. And there is growing acceptance for these liquid-based biomarkers in clinical practice, as evidenced by EGFR testing now coming in guidelines for non-small cell lung cancer, or PIK3CA mutation is advisable to do on blood when there is non-availability of tissue sample. So yes, there is more and more inclusion of these non-invasive biomarkers in clinical practice. CTC enumeration, as we know, is FDA approved for prognostication for certain malignancies like breast, colon, or prostate. However, there is now the research focus is also now on CTC clusters, that is clusters of circulating tumor cells or their associated cells, and whether these can be explored for their utility in clinical management. So CTC clusters are actually not new. They share similar long history with CTCs. First recognition of clusters dating back to 1950s. The exploration of clinical significance of these clusters started around 2000s. And in 2015, there was a first device especially customized to isolate CTC clusters instead of solitary CTCs. So yes, their potential is being increasingly realized. What are CTC clusters? They are also referred as circulating tumor microemboli or micrometastasis or circulating tumor aggregates. These are nothing but ensembles of group of tumor cells which travel together in bloodstream. The prevalence of these CTC clusters may be underestimated currently compared to solitary CTCs, may be due to the platforms which are being used for detection of these clusters. For example, microfluidic devices may hamper the aggregates or CTC cluster isolation because of the shear forces of the microfluidic systems, or in filtration-based technologies, the pore size may hamper that enrichment. Studies have postulated higher metastatic potential. For example, a study by Achito et al. Did highlight that CTC clusters have 30 to 50-fold increased risk of metastatic potential compared to solitary CTCs. And thus, of course, they are associated with a poor prognosis compared to a patient having only having solitary CTCs versus CTC clusters. Study by Ho and colleagues did analyze clinical significance of these clusters and concluded that against solitary CTCs, which may have higher subpopulation of apoptotic cells, the CTCs in clusters are not apoptotic. This survival advantage of the cells in clusters is probably because of the very reason that anoikis, which is an apoptotic cell death pathway, is initiated when cell to cell or cell to matrix adherence is lost, and which is the case in solitary CTCs, whereas in clusters, because there is preservation of the cell to cell anchorage, there are more resistance to apoptotic cell death following their dissemination in peripheral blood. This may also be the reason for their higher metastatic potential, that they survive longer in the peripheral blood. Studies have been undertaken to know whether the clusters are result of either intravascular aggregation, that is, solitary CTCs did get access in the peripheral blood and the aggregation in the form of clusters happened in the peripheral blood, or did they originate from the tumor proper. It has been showed that CTC clusters are derived from multicellular groupings from the primary tumor cell. And these cells are held together through anchorage by a protein such as plakoglobin. The CTC clusters do not result from proliferation of these solitary cells in peripheral blood, neither are they result of the aggregation of the cells in peripheral blood. Instead, they appear to represent a microbiopsy of the primary tumor mass. Their intravasation or their accessibility in the peripheral blood has been thought to be contributed by the leaky or chaotic tumor vessels, and appearance of these clusters in blood is as a result of collective migration of these tumor cells from the tumor proper, as it was highlighted by study by Ho and colleagues. So this differences between solitary cells and CTC clusters, that the CTC clusters are protected from apoptotic cell death compared to solitary CTCs, or they do originate similar to CTC from tumor proper, makes it relevant to incorporate CTC clusters in analysis of liquid biopsy along with solitary circulating tumor cells. Methodologies based on CTC isolation or cluster isolation are such as true blood will face multiple difficulties. For example, as it is highlighted on the earlier talk, these are very rare events on background of billions of normal red blood cells or white blood cells in peripheral blood. Also, as we discussed, there is apoptotic cell death which might take place in solitary CTCs, or clusters, because they are large in size may get entrapped in smaller blood vessels, leading to a shorter half-life. And the enrichment methods which focus on epitopes such as EpCAM-based isolation may face difficulties when there is epithelial to mesenchymal transformation, leading to downregulation of these epitopes. And we already discussed the limitations which might be need to be addressed on filtration or microfluidic based devices. So all in all, there are multiple difficulties which need to be addressed to ensure adequacy of enrichment or isolation of these clusters and CTCs, so that we get enough amount of these cells to conduct some meaningful downstream analysis on these. A true blood methodology was developed at DATA to focus with a focus to address all these constraints which are either faced with a tissue biopsy or a liquid-based approach utilizing solitary CTC or circulating tumor cells. True blood utilizes a label-independent, size-independent, and non-mechanical approach to allow enrichment of viable apoptosis-resistant cells from peripheral blood. And it not only isolates the solitary CTCs, it also isolates their clusters. After validation in large clinical trial and observing that circulating tumor ensembles or clusters are ubiquitous to cancer, and they are very rare or uncommon in individuals with either benign conditions or healthy individuals, true blood methodology was validated in a prospective clinical trial to show see its utility for cancer diagnosis. So we are repeatedly referring to ensembles or clusters of CTC. As I mentioned earlier, they include solitary CTCs. They may have some tumor-associated cells like macrophages, lymphocytes, or even in certain situations, certain stem cells. For true blood, the criteria was there should be 3 or more nucleated cells in that cluster. So these clusters were harvested from peripheral blood by a negative enrichment method, and the novelty of this approach was mainly in utilizing an epigenetically activated media, cell-stabilizing media, which will induce cell death in cells which are normal or which have intact apoptotic mechanisms such as hematolymphoid cells, and paradoxically giving survival advantage to the apoptotic resistant cells such as CTCs and their clusters. After enrichment of these clusters, they were gently dissociated and transferred on coated slides or in multi-well plates. And then they were stained with immunocytochemistry and with organ-specific antibodies. And this was followed by detection using a high-content screening platform. There was much focus initially on the development of methodology, selection of particular markers to detect the cross-reactivity, or all these factors were incorporated before analytical validation was undertaken. And after successful analytical validation, clinical validation was undertaken in prospective clinical trial. In this prospective trial, the patients who were presenting to clinics with suspicion of cancer, who were advised for tissue biopsy but have not yet undergone a tissue biopsy, were enrolled after an informed consent. 15 ml peripheral blood was drawn, and it was processed on True Blood platform. After sharing the True Blood report, the histopathological examination concordance study was undertaken to determine the performance of True Blood test. So the first study included more than 16,000 participants, and there were healthy individuals, there were patients with known diagnosis of cancers, and in this cohort we saw that CTACs or ensembles or clusters of CTCs are present in over 90% of cancer patients, whereas they are only present in less than 3% of the healthy population. Total 5,509 or over 5,500 cancer patients and 10,000 healthy patients were included. The detection rate across various organs did vary, but it ranged between 83 to 94%. So additional analysis was conducted after seeing that these clusters are ubiquitous in cancer and not present in asymptomatic or healthy individuals. These healthy individuals did undergo corresponding screening methodologies such as LDCT or pap smear or mammography was undertaken to ensure that at least with current conventional screening modalities, there is no cancer present when the patient has the healthy person has submitted blood sample as for a negative control. So additional analysis with organ-specific biomarkers was undertaken, and we have published this data too in cancer cytopathology. And this was a pan-cancer study to evaluate performance of True Blood. So with total of 30,000, more than 30,000 patients, there were 9,416 cancer patients with a diagnosis of cancer. There was a cohort of 6,725 patients who were prospectively enrolled and on suspicion, or they presented to a clinic and clinician had a suspicion of cancer and they're scheduled for a biopsy. There was a detection rate of 91.8% with these CTACs in cancer patients. And in the prospective cohort where a biopsy was performed after the blood sampling, 92.6% patients with a prospective diagnosis of malignancy did show presence of clusters. And in 700 benign patients, like 700 patients with a benign diagnosis on tissue, when organ-specific markers were implemented, only 0.7% patients did show presence of cluster. So this data again highlights that it is a very specific and sensitive tool where we are faced with clinical difficulties and where physical biopsy is not feasible. As I said, the detection rates again in this study ranged from 86 to 97% for the CE tags. And when there was organ-specific concordance study undertaken, the organ-specific concordance varied between 80 to 100%. So I will just show you brief certain images which were performed on some of these patients. So we use common epithelial markers such as cytokeratin and NetCam, but we do not stop there. We also incorporate organ-specific markers. For example, in this case of colon cancer, we can see the SATB2 positivity, which is very specific for colon. And also there was positivity of CDX2, and along with positivity of markers such as CK20. And together, along with this positive markers, the panel always incorporates markers which should not be positive in these specific malignancies. So of course, to begin begin a true blood analysis, there has to be a close differential on a clinical judgment. For example, there is a lung mass and a primary from lung is suspected, or with a close differential of some certain other organ, that is a requirement, and that is why true blood is not proposed for cancer of unknown primary, or even as a patient who just has a person who does not have a particular systemic indication for malignancy, a particular system involvement for malignancy. These are other representative images from lung adenocarcinoma for napsin positivity. CK7 positivity can be seen here. And of course, simultaneously, there is always a staining of WMC marker like CD45, and DAPI staining is undertaken to ensure that we are focusing on the nucleated cells. This is another representative image for P40 positivity from a squamous cell carcinoma. So with these results, especially when we have enough number of cells at our disposal with an approach of true blood, which utilizes an epitope independent or filtration independent approach, there are enough cells isolated from across malignancy, across stages, and they can, because of the availability of such good number of cells, we can provide a broader panel of organ-specific antibodies to give a possible indication, not only for presence of malignancy, but confirmation of primary organ of origin. So as a follow-up to our earlier study in asymptomatic cohort, we did follow up these 3% patients asymptomatic cohort, which had shown presence of clusters at the blood sampling. And on a prospective follow-up of 1 year, CTAC positivity was shown to confer a 230-fold higher risk of 1 year cancer occurrence of cancer in following year as compared to individuals where CTACs were undetectable. Considering that CTACs are extremely unlikely to be influenced by ethnicity or ethnicity, thus the present strategy can offer a viable approach for stratification-based screening of this population, and that is our focus for future research and future studies. And the high sensitivity and specificity of CTAC detection can definitely facilitate accurate triaging for at-risk individuals. So, and it's not only the future for screening, but currently, along with cell-free DNA, the CTCN clusters can be profiled for very relevant theranostic markers, so that they can give therapeutically relevant clinical information at present. So with thanking all the participants and organizers, I'll summarize the topic. True blood utilizes circulating tumor cell ensembles or clusters, and these clusters have been proven in literature to originate from tumor proper and are not result of cell aggregation in peripheral blood. That as shown by our large data in over 30,000 total cancer and asymptomatic patients, we can say that they're ubiquitous in cancer and relatively uncommon in benign tumors or in individuals who are healthy or do not have prior history of cancer or current are not suffering from cancer at present. These CTACs can be profiled for by immunocytochemistry because they are available in large numbers in true blood approach with organ-specific markers. Detection and characterization of CTACs can non-invasively provide diagnostically and theranostically relevant information. And thus, in cases of suspected malignancy, diagnose and with difficulty to achieve a tissue biopsy, they can definitely provide a diagnostically relevant information. And they can be a very useful tool for diagnostic triaging in this set of patients. And when coupled with ctDNA, as I mentioned earlier, they can provide a significant additional theranostic information. Thank you all.
Thank you, Darshana. That was a wonderful presentation and a curtain raiser to True Blood and a novel method of testing for early detection of cancer. It is talk of town. I think there's a lot of questioning around this. There's a lot of buzzing happening with interest. And I think one of the things that stands out is that it is it's an innovation that really disrupts the routine thought process. So obvious question, how do you implement this in the clinic, and which patients would you suggest this would be applicable for?
So this is very relevant because currently we do tissue biopsy is still the gold standard. Liquid biopsy is evolving. There is much literature evidence supporting its use, but still it is not there. So obviously, where in patients where you have easy accessibility to tissue biopsy, maybe you do not want to consider such novel approach. But where patients where you are stuck, you know there is a presence of a suspicion of cancer, there is presence of malignancy, and you're not able to have any conclusion or conclusive evidence on a tissue or fluid cytology, definitely True Blood can be considered.
Fantastic. So the other question comes in from one of the viewers here. Does CETAC burden correlate closely with single CTC burden or CTC cluster, or independent of the CTC burden? You know, does the CETACs and CTC burden correlate to each other?
So there is close, like the percentage is similar, like very close, but not necessary. There is absolute concordance with solitary CTCs and clusters. For example, in certain, we did observe that in certain malignant organ types, that prevalence of clusters is higher. That's why that can be seen with a differential sensitivity. In certain organ types, we did have 100%, like 96% sensitivity, and in certain it was close to 83%. So it does correlate in certain types of patient, and in certain cohort it doesn't.
Okay, great. The next question comes from Dr. Kumar Prabhash himself. He asks, is there any external validation done for this yet?
So when it came to development of True Blood, the data was blinded. There was clinical participation from Indian institutes such as HCG hospitals, and the data was blinded. Data was then matched, and we did also have for certain malignancies such as glioma association with international institutes also. But currently, a prospective clinical validation located in outside institute is being planned, like external institute is being planned.
Okay, thank you. So another viewer asks, can you please tell what are the main markers? I think this is a digression. I'll reserve this question for later. I would ask a final question here. In terms of True Blood and you know, the medical legal scenario right now in the world, including in India, if we had a patient who could not get the biopsy done, and I have reached out in that setting, do you, when you do True Blood, do you look at the circulating tumor associated cells, and do you also look at the ctDNA for that patient? Do you look at a particular cancer or the suspicion of a particular cancer? How do you go about testing the CTACs? For which marker? Would you test it for lung? Would you test it for breast? Do you ask for more radiologic information or clinical information for that patient? How do you go about doing your testing?
So for True Blood, there has to be some guidance about probable organ of origin. Of course, not only one that there is only lesion in lung, but a close differential between two or three organs should be indicated based on the clinical feedback, because finally we are using similar markers what can be used on tissue biopsy for IHC, and there is always, as with tissue sample, there is always constraint of availability of tumor cells also from clusters. How many antibodies can you use to from one sample? So there has to be a close clinical suspicion, at least for close association between two or three likely primary organ of origin. And to answer the second part of the question, whether ctDNA is incorporated, ctDNA is a part of, can be availed as a part of complete true blood investigation, so that theranostic markers can also be simultaneously provided along with the diagnostic triaging provided by the true blood.
Okay, that's a great thought. I'll just, as a closing, I'll share that I have done true blood in circumstances where the patient has just not been able to do a biopsy, and in such a situation, giving the organ of suspicion and also sort of doing a complementary ctDNA analysis for these patients has helped me come to a conclusion with the help of true blood testing. Thank you, Darshana. That was a wonderful talk and curtain raiser, as I said, in the world of early diagnosis with the help of circulating tumor associated cells. So we talked a whole lot about circulating tumor cells. There's a world of knowledge that is happening around circulating tumor associated cells, and we discussed some of that in early detection just now. I hand over back to Dr. Prashant, and I think I'm going as the next speaker. I'm fully unprepared for this talk, but happy to chip in as an extension for Darshana's talk, because this is how I work. So Prashant, please go ahead. I think we've already introduced me, so I can actually just go ahead with my talk.
Okay, so let me briefly tell, thank you, Dr. Darshana, very exciting work. And there are multiple questions I could see in the chat box. There are a couple of questions from Dr. Shyamla Maheshwaran, and I could see the many more questions. So I would request you, whenever you find time, please answer those questions in the chat box. Okay, sure. So thank you very much. So our next speaker is Dr. Sevanti Lime, and she's the co-convener of the meeting. And I'm very excited actually to introduce her today. She's a friend, colleague, and a true leader, I would say. She's holding a Director Clinical and Translational Oncology Research, Director Precision Oncology at Kokilaban Dhirubhai Ambani Hospital. She worked in medical oncology field, and she also worked previously Assistant Professor of Medicine at Columbia University, New York. She specializes in treatment of all solid tumor, including breast, lung, head and neck, GI, GU. She has specific expertise in cancer genomics, targeted therapy, and cutting-edge treatment and immunotherapy. She has led several national and international trials and has been a part of a data safety monitoring board. Dr. Lime was awarded the John Phil Young Investigator Award for Excellence in Clinical Research. And this is something extraordinary, I would say. The Rose Jack Horowitz Award for Excellence in Patient Care. Medical Oncology Research Excellence Award, ASCO 2008, for Excellence in Clinical Research. She was recently nominated to serve as the National Chair of the Sub-Protocol Arm B of the landmark NCI batch trial. Nevertheless, she is what is something make her very different, I would say, that she's very committed to the development of novel therapeutics in solid tumors. So it's a really great pleasure to welcome Dr. Lime. And today she's going to speak on liquid biopsy, the management of rapidly progressing cancer. Thank you, Dr. Lime.
Thank you, Prashant. So this is what you meant when you said you had a surprise coming. Okay, so I'm going to talk about how how I practice in my clinic and how I implement liquid biopsies. So we discussed about how liquid biopsy was so center and core in different malignancies. We talked about breast cancer, we talked about lung cancer, and we talked about early detection. This is an extension of that theme. So I, as an oncologist earlier, identified myself as a clinician investigator. And now I feel I'm very sort of integrated with precision oncology. And I also feel that there isn't any other way of really practicing oncology rather than trying to be precise. I think all of us are trying to do that job. And how do we do that in the current times when it is all the trials that are happening are actually organ specific or pathway specific. So when we talk about standard of care management, I think specifically when I moved over to India, I realized that we were really deep into discussing standard of care management and guidelines. And that is what we were driving. We were really driving home that one had to practice cancer therapy in a guideline driven way. And in my heart, actually, I was already moving away from a lot of the organ specific guidelines and moving towards organ agnostic pathway driven therapy, wherein it was a taboo to actually take over information from one malignancy and go into the other. But I think the world is moving towards that. And some of that information comes in mainly because when you look at the guidelines, a lot of the guidelines would still not discuss repurposing of the drugs. But a lot of the thought leaders in the world are already going ahead and doing that. Mainly because when we talk about guidelines, they are developed over a period of time. You look at the stage of the disease, you look at whether this is loco-regional, whether this is distant disease, which mutation is driving the disease, whether this is targeted therapy or this is endocrine therapy, which arm of the study would you enroll the patient. And mostly the clinical trial designs even today appear to be very limiting. Why is that so? Mainly because when I go to a head and neck basket study, even today, it's mostly with one pathway at a time. And we all know that it isn't like that for cancer. It's an ever evolving adaptive transformation that cancer cells go through. And the question comes in, should we be looking at organ agnostic and label agnostic therapies? And that is a message that I have, I started looking at from my Columbia days, wherein I participated as a co-investigator in an N-of-1 study that was being led by Dr. Andrea Califano, who was the director of the Columbia Genome Center. And I was one of the co-investigators on that study. And in that study, essentially, you brought back the information from a live tissue sample that you took out from the OR, and you made mouse avatars out of that sample. And then you treated the mice with different drug combinations. And you brought that information about which drug worked for the mouse to the clinic, to the clinician whose patient it was. And having participated in that, the concept design of that study, I was very intrigued and actually really something that got into my heart. And through that, then, the Shiva trial results, and also as a young investigator, I was writing up one of the arms of the NCI match trial. And by the time the trial arm was being written and being readied to be offered at different sites, already we knew that the match trial design was getting old, because there were many more options that had come through for several of these malignancies that were being represented in the study. And applications of combinations, applications of multi-pathway inhibitions were also coming in. So already the trial was looking old during the development. And that's where the theme of one size fits all is not going to work. By the time you target one pathway, you will have a longitudinal evolution of that pathway, and you may need to inhibit from another side. And the realization that NCI match itself was not going to be enough. Many treatment arms were open in NCI match, and if you really looked at the results of most of these arms, one of these were the arms that we had written, the arm B, the responses were really dismal. And that brought in the message, were the precision trials being designed in the correct way? And when you looked at the host of clinical trials that were being designed, most of these were with single agents with the help of 4 mutations in my pathway, to 39 arms with unique alterations in NCI match, and multi-gene analysis where array CGH and RNA-seq and IHC and whole exome sequencing was being used, but still single agent or rare combinations. And if you really see, the combinations were the ones that were standing out, including a phase 1 retrospective analysis done by MD Anderson, where the response rates were high in the range of 27% in comparison to where you had very specific single mutation driven therapy, wherein the responses were limited and to the extent to be called dismal. The message that as a clinician I take from these results is a single pathway was really not enough in an ever evolving cancer patient. A cancer patient where the chemo resistance develops as you go along within months of therapy. And how do you then just stick around with one treatment when the treatment is not lasting long enough? And through the interactome that you have of multiple pathways that are seen in cancer evolution, how do you just stick around with one therapy or one pathway directed therapy? And that's where I feel a multi-analyte interrogation of the tumor is very valid. And that's something that I saw in the trial that was run by Datar Cancer Genetics Limited, and something that I have brought into my clinical practice as well, wherein they ran a resilient trial, which was a precision oncology trial based on integrational multi-analyte molecular and cellular analysis of tumor. It was a phase 2, phase 3 study, prospective single-arm open-label interventional study, wherein patients had already received multiple lines of prior therapy or had non-availability of standard of care in a particular setting. And they used what they called encyclopedic tumor analysis, essentially a DNA, RNA, IHC chemosensitivity based comprehensive analysis, and then interpretation of that analysis with the help of computational software, and also with the help of molecular tumor board within the system, wherein they figured out a comprehensive treatment result for the patient. Now, I say this because I have utilized, in most of my patients, I have utilized beyond just DNA. And I really seek out DNA and RNA, IHCs. And why do I do that? Mainly because it's a struggle just to be looking at a single mutation and target that mutation and expect that the patient would really have a magical response. So when you look at this trial, they had 150 patients almost. They had multiple different cancers. I'll go through quickly because I have to get to the liquid biopsy part of it. They ultimately, the previous treatment that the patients had had was 95% of these patients had been exposed to cytotoxic therapy, some to targeted therapy, surgery, radiation, endocrine therapy. And a whole host of these patients were then offered cytotoxic, targeted, and endocrine combination treatment on the trial. And the reason why a multi-analyte based testing would result into this kind of an answer was mainly because you were looking at DNA, RNA, chemosensitivity profiling, as well as the IHC testing. And this is the waterfall plot of responses. And you had an overall response rate of 42.9%, a significantly comparable number when you look at the other studies that have been done, wherein you have response rates ranging from anywhere from 4% to 27%. And in comparison, this really stood out with a significant progression-free survival. And one of the ways to test the progression-free survival relevance was to look at whether the previous progression-free survival was being doubled or more than doubled by a particular therapy. And in this, there was a 2.5 times increment to previous treatment in 35% of patients who responded, and in and more than 1.3 times in 75% of patients who responded. And many stories like that, where the patients had had multiple lines of therapies and a completely organ agnostic regimen was then offered to this patient for response. And here again, there's a neuroendocrine tumor of cervix who has received previous 4 lines of therapy and is found to have EGFR overexpression, ERBB2 overexpression, KIT overexpression, and RET overexpression. And this patient was offered oxaliplatin, erlotinib, and axitinib, and you can yourself witness the responses. These patients were treated on the Resilient trial, and again, significant responses in a patient with previous 5 lines of therapy, melanoma, patient not able to afford immunotherapy and not having standard of care immunotherapy available, and again treated with a combination of chemotherapy and targeted therapy, which was very unique and not published. And this is a head and neck patient who was again had previous 3 lines of therapy, and pictures worth 1,000 words, was treated with chemotherapy, axitinib, and everolimus, targeting different pathways. Another breast cancer patient with prior 10 lines of therapy, here responding to temsirolimus and dasatinib. So again, multi-analyte testing and application of all this information, amalgamation of all this information and application for the patient. But there are challenges, and the challenges are requirement of fresh tissue. Most patients do not want invasive biopsies. They do not want longitudinal biopsies. And how do you figure out for these patients whether their evolution, the tumor is in evolution, and what kind of therapy would really work for them? So in the next trial, there is this attention to cell-free tumor DNA and ctDNA testing, exosomal mRNA testing, and circulating tumor-associated cell testing in liquid biopsy for these patients in a trial that was called Liquid Impact trial, wherein it was a precision oncology trial again with non-invasive integrational multi-analyte circulating markers in cancer patients. And you had 74 patients initially, but intent to treat was 51, and evaluable patients were 43. It's a provocative study, I would say. It is a study that brings to mind that, so I would say this is audacious to really attempt a multi-analyte testing and to attempt to treat patients on that basis. But it's demonstrative that such a method can be utilized and can be put to effect in patients who are heavily pre-treated, and where we utilize multiple different methods of identification of the right therapy for the patient, including live cell chemosensitivity analysis and immunocytochemistry analysis. And here, if you see, multiple different cancers were treated, and you had 17 patients where there were no actionable molecular alterations. And where do you go with such patients where you don't have any molecular alteration? And isn't this a common reality in our practices that we see every day? And that's where, if you look at the expressions, the other markers that could be really utilize to hit a cancer patient. They have an entire list, and different cancers where they had mTOR as an indication, EGFR as an indication, and for VEGF also anti-angiogenic indications for which they utilize anti-angiogenic agents to treat these patients. And so 10 patients received mTOR inhibitors alongside other therapies, 18 patients received angiogenic inhibitors, and 8 patients received EGFR or ERBB2 inhibitors. And these are the responses. When you look at the waterfall plot with best responses and status at data lock-in, there were significant responses in patients who were included in this cohort. Partial responses were seen in 14 out of 43 patients. Objective response rate was 32.6%, and 18 patients showed stable disease, which lasted for 6 days. Remember, these are heavily pretreated patients, and this amounted to a disease control rate of 74%. And similar waterfall plot showing efficacy with the help of combination therapies and a progression-free survival for these patients that were significantly treated in the past. Some cases to end my talk, and here a patient who had endometrial adenocarcinoma, 45-year-old female, where you see patients was already treated with radiation, brachytherapy, carbopaclitaxel, docetaxel, cisplatin, and underwent Exacta testing, the liquid impact testing at that time. And here you have on immunocytochemistry of the circulating tumor-associated cells, you had representation, and you could give lenvatinib mTOR on ICC for everolimus, and the chemosensitivity that was performed was able to offer vinorelbine and vinblastine as the treatment. The patient received this combination therapy and had a progression-free survival of 8.2 months and overall survival of 11.2 months and ongoing, so still continues to be alive and benefiting. Again, the next patient with an unknown primary, very difficult case where poorly differentiated carcinoma treated with carbopaclitaxel, very early on decided to do Exacta, and axitinib plus gem cisplatin shows benefit here in this patient, and again, significant advantage in progression-free survival and overall survival. This is my own patient, wherein multiple previous lines of therapy were given to this patient. This is a colorectal patient who's gone through. So this patient is actually all RAS negative, really no markers to target, TMB, low, MSI, stable, no significant markers to hit the patient with. Patient received FOLFOX and cetuximab. Patient then received FOLFIRI and bevacizumab on progression, then went back to FOLFOX and panitumumab, and then 5-FU, leucovorin, and panitumumab continued. Significant progression at each step. Regorafenib alone failed. Cyramza, irinotecan failed. So multiply heavily pre-treated, and now comes down to a liquid Exacta, wherein a multi-analyte testing and a chemosensitivity analysis tells me that he should respond to methotrexate and cetuximab and regorafenib, and these are the results that you have in front. So, near complete remission of all the lesions, CA markers really down, and patient becomes asymptomatic. This is actually an interim scan. I did not, for the talk, I did not have the previous scan wherein the disease burden was even higher. And so the patient has been for 11 months on this regimen, which is an unpublished regimen. We've also published two another such case studies wherein an ovarian cancer patient was treated with liquid Exacta, and another patient with cholangiocarcinoma was treated with liquid Exacta guidance. So at the end, the main point I would like to make here as to the ever evolving nature of cancer leads to great difficulties with treatment, specifically if you are doing longitudinal biopsies, which most patients refuse. And in that setting, if you were to just do DNA testing and that to ctDNA in blood, we are all left with single pathways and limited chances of finding single pathways, mostly in the range of 10 to 12% if we get lucky. The question is, how do we get beyond that? And I know the field is controversial, but I've always felt that if we wait till we get perfect, 100% perfect, it'll be late for many, many, many patients. And for that very reason, I personally believe in chemosensitivity profiling. I know it's an evolving field, but I have believed in that. I believe in tissue chemosensitivity profiling, and I also believe in liquid chemosensitivity profiling. And the idea here is to try and figure out the cancer evolution and therapy resistance, and the ease of liquid biopsy allows it differently. With that, I thank you, Prashant, for this opportunity. And I'll just take a moment to also thank DCGL for sharing the data.
Thank you, Dr. Sevanti. It's an exemplary talk, I would say. And I would just ask a couple of questions. And because we are running late, so I may not go much in detailing more of the questions. So could you please tell me that what about the unknown primary? What is your experience handling with those tumors, and how often the liquid biopsy help you in the diagnosis?
Yeah, that's a great question. And Prashant, when we are looking at an unknown primary, one would try to actually get a rough idea as to where the disease was coming from. If you really don't have any clue, no clue at all, in that case, I tend to do tend to study what can you do about that presentation. So if you can't figure out where it is coming from, what do you do once it has already come? Can you figure out methods to treat once it has already come? And in doing that, I usually do a ctDNA analysis and as well as a chemosensitivity analysis, because I have to ultimately treat that patient. So the challenge is in the clinic, because you have the problem, I have the problem in front of me, and I cannot sit down in front of the patient and say, this is the pathway, that is the pathway, I'm going to try and figure out, but I'm sorry, I don't know. That can't be the answer. I have to find the solution. And in order to find the solution, I try to go as comprehensive as possible and try to get an answer to the problem and the solution to the problem rather than finding the specific problem. So two things I do. I do the DNA RNA analysis, and I also do the chemosensitivity profiling. I have utilized a couple of previous tests, tissue of origin tests that is in the market. I know there is another cup test that is there, and mostly these tests are able to come back to you and they use gene expression profiling to tell you which exact category the cancer may be belonging to. But the problem with such tests is still that it does not change the destiny of that cancer. It will just tell you that it may belong to breast. But if you look at the cup survival data, the survival for any kind of cup is still very poor. So the bottom line is you are trying to crack the case, and knowing the primary is great. And so one could invest in knowing the primary. But if I had to really figure out my resources, I would invest in trying to know the solution to the problem. And that's where what Caris did is look at, for cup, it looked at all the molecular signatures in cup. And I would extend that further to look at the chemosensitivity for cup patients.
Excellent. So there is an excellent comment from world leader. So Dr. Klaus Pentel has joined the meeting and he has just posted a comment. So it's a wonderful talk, Sevanti. Great work.
Thank you.
There's another question from Dr. Rick Thompson. Again, great talks, Dr. Sevanti, and terrific results. The question is that, can you estimate what proportion of cases that you undertake the multi-analyte analysis give you effective leads for beneficial treatment?
That's a great question. And actually, with that question, so I have started a precision oncology clinic, and we are gathering all our data. We are tracking our patients. This is a new development. We have already seen 100 patients and over in the precision oncology clinic. We are tracking our data for the DNA RNA based testing that I'm doing versus DNA RNA plus chemosensitivity analysis. So I would be able to come back to you very soon, because right now all I would give is anecdotal, and I have many anecdotes like this. I have a melanoma patient where I'm treating with tumor exacta, the exacta testing that I presented, who's responding to 5FU plus imatinib. So did not respond to imatinib, c-KIT mutation, chemosensitivity showed 5FU, responding to 5FU imatinib. So I have many such patients where the treatment is being done with a multi-analyte approach, and it shouldn't be anecdotal. One should be able to compare them head to head and bring back the answer more specifically. I should be able to get that information for the next liquid biopsy meeting. Thank you for the...
Dr. Limay, so this will be a memorable evening for you, because you got another comment from another world leader, Dr. Shyamala Maheshwaran from Harvard, and she has written, "Congratulations on your talk."
Thank you. That's a huge honor, and a huge honor for me to be hearing this from all the world leaders. The work is not mine. The work is Datar Cancer Genetics Limited. But as a thought leader, I have single-mindedly pursued this, mainly because of the because I feel that one pathway is not going to be able to give the answer, and I learned it very early as a part of that N of 1 study. And when I saw the resilience study, which was initially being brought to me, I basically had that same comment. This is ahead of the times. I don't know where it will go, but it is thought-provoking, and it is definitely brings in a different message to the platform. So I'm really grateful that everybody liked the talk, and thank you for giving me the opportunity.
Thank you, Dr. Limay. So we will now move, and again, it's my great pleasure to introduce Dr. Kumar Prabhash. Can you please, the introduction slide? Kumar's introduction slide. Team, yeah. So I think most of the people in India, they know Dr. Kumar very well, especially in the field of oncology. And I would say that he's a leader, and you would enjoy his next 50-minute talk. Dr. Kumar is a professor, head medical oncologist in Tata Memorial Hospital, and we call it the premium hospital in India. He has more than 2 decades of experience. He is present president and convener of Indian Cooperative Oncology Network, ICON, we call it. He has so far published over hundreds research paper review articles. And believe me, these are very high impact factor journals he has published from India. He has so far undertaken, I would say, more than 100 projects as a principal investigator and co-investigator. He's a member of many international and national scientific societies and associations, and has delivered talks in several meetings, India and abroad. Dr. Kumar has significantly contributed in translational and clinical research. And he is known as a leader in the area of lung cancer. And something I would definitely like to mention, Kumar, one of your paper where you have done, I think it's more than 1,000 patients. And this was a benchmark work where they found the EGFR mutation ratio or the frequency was different from the Caucasian population. And this is something which was given a big boost to the Indian clinical research or the oncology field. The Indian data is really important for us to follow and to understand the depth of the precision oncology. Dr. Kumar is a dedicated and he has created awareness, I would say, in lung cancer field and with utmost importance to the patient care and strengthen the future research in India. So it's really, really my great pleasure to welcome Dr. Kumar Prabhash.
Hi, Prashant. Can you see my slides?
Yes, yes.
Good evening, everyone. And at the outset, let me thank Dr. Prashant and Dr. Sevanti for giving me this opportunity today. And these are why the friends are. They need to talk nice things about the friends. And thank you for your kind words, Prashant. So what I'll do is I'll talk in brief about the liquid biopsy in lung cancer. I'll try to be as brief as possible. I'm sure everyone will be missing their dinner. Starting with liquid biopsy, I'm sure we have talked about it, where you can do it from, what we do and where you get it from. Any fluid, and then you have from CTC to ctDNA, exosome, platelet, microRNA, wherever you can get those molecules from. In lung cancer, there has been some good work for early diagnosis. This was a randomized trial presented, which was primarily based on ELISA test in the blood. And what it showed that if you do it, you pick those early cases more as compared to if you don't do it. And this was after 2 years of randomization, suggesting that this needs to be explored further. Subsequently, someone tried to combine microRNA assay with low-dose CT scan and try to see, can we avoid more low-dose CT scan in these patients? And this was again a randomized trial based on microRNA, having patients multiple CT scan versus having only one CT scan. And what they found was that if you have those, any one of them positive, either CT scan or microRNA in blood, the chances of patient having lung cancer was higher. But if we avoid those CT scan, there was no detrimental effect in detecting the lung cancer in these patients. So again, a promising result, but again, as it happens in medicine, you need to have some more data before we are more comfortable about it using in clinic, suggesting some good promising role. Now coming to the diagnostics, especially the mutations where we are more concerned about it, that can we detect them? As we heard from previous speaker today also for diagnosis, that it is lung cancer or not, by and large, today worldwide, we depend upon having a tissue, seeing those cancer cells in the microscope. And it's very uncommon that we skip that step. We do come across situations where it becomes tough, but by and large, we depend on that. But if we have to see those mutations, and where we always have an issue regarding how much tissue you have after diagnosis, this data suggested for some common mutations and how good is the concordance. And it looks very good. Around 98%, 100% positive predictive value for these patients. So it looks very promising. Another study suggesting almost 89%, again, confirming that if you do the test initially in the blood or in the tissue, the common mutations, what you see is you get similar results. Again, important word is similar. We'll come to that issues when we say this similar result. Is there some more data to it? People also try to compare tissue and blood for mutation positivity overall. And they found that if you do ctDNA versus if you do blood, and it appears again you have get a similar kind of positivity rate for those common mutations in these patients. This was our own work, which we compared the ctDNA, and we compared the ctDNA with the tissue. Overall concordance was good. True positive rate was good. True negative rate was good. Important was sensitivity, and that's the problem with the ctDNA based test, that if you detect it is great, but you do miss it. Here we missed around 10%, but remember it was only for EGFR here. The more the number of mutations you keep adding, the more the number of genes you keep adding, you do start missing more in these patients. So concordance will be good, positive predictive value will be good, but sensitivity goes down, and here it was 90%, but in general in lung cancer it remains around 80%, and again it depends upon which gene we are looking for and which mutation we are looking for. Again, talking a bit more about liquid biopsy in lung cancer as compared to tissue biopsy, it is easily possible. You require far less resources. It also gets reflected in the clinic, because when they come to to the doctor after having seen many people, when they meet, only 21% patient has the biomarker test, because getting those tissues, biopsy, and getting those tests is a challenge in lung cancer. It also gets reflected in another data, that if you do all the mutations which is required today in lung cancer, for which we have a drug, only 18% patient you can do those tests with the tissue today, especially if you do sequentially. We do agree, we do have NGS now, which can do all these tests in one go, but in that case also, good number of patients won't have tissue where we can do all these tests in one go in these patients. And again, the value of liquid biopsy comes in. This was again our own work, which gets reflected that almost 1/3 of our patients, either tissue was not enough, or doctor or patients were not willing to wait for molecular report because of one is tissue being not good, or amount not being good enough, or the symptoms were more and the report takes enough time that the patient was not willing to wait. And again, we think in this situation, liquid biopsy can be a good alternative. If you do a repeat biopsy, which is now common in lung cancer, as talked by some of the previous speakers, in our population, almost 40% of the patients either couldn't undergo test, or they didn't have adequate tissue in the repeat biopsy to do this test. Again, highlighting that you need to have an alternative method, which may be a bit less sensitive, but it is useful for our patient in this setting, because tissue is not giving us the answer what we want. How safe it is to do this comparison of biopsy versus doing a liquid biopsy, I'm sure it goes without saying that it is easy to implement. It is far safer for our patients. How efficient it is if we use this test in our management, and if we compare tissue versus liquid biopsy, amount of time taken is less in these patients. At the back of the mind, we need to remember the sensitivity being lower. Again, doing this test, the human resource requires is lesser in our patients if we do this test. Do we pick up more mutations? And when I say sensitivity is less, that doesn't mean liquid biopsy doesn't pick up more mutations. They do lose some more, but they do pick up some more. But overall, they do pick up a bit lesser than as compared to overall the tissue biopsy. But if we do compare liquid biopsy separately with tissue biopsy for picking up more, then they do pick up some more tests. So there is some advantage to it, and I'm sure one can always debate, should we do both? And I'm sure we can have those discussions later. Can be done at the places where you don't have access to, many times we think older technology is far more accessible. Remember, I'll show you an example. That's not always true. And this is not always true for, this is also not true for having a biopsy from the lung lesion and having a tissue and then doing those mutation testing. Because getting an intervention radiologist, getting a chest physician who can use EBUS to do those tests, it is very tough. Hardly beyond tier 1 city, you will get someone who can do these tests, do these interventions to get those tissues. But you can get this blood test done, because for most of the good lab, you do have people who can collect those samples and get this test done. I'll come to that slide later on. What we can see, look for in future, what we want to know. We want to know the minimal residual disease in lung cancer. We want to segregate the patient depending upon the responses. And we all know, this goes without saying, that as far as the future is concerned, for these questions, the cell-free DNA or liquid biopsy has some answers to it. I won't say definitive answer at present, but sure, I don't think so. We will be able to have this answer with tissue biopsy. This was our work where we did liquid biopsy for each of our mutation positive patients between 2 to 4 months, and we divided those patients where the liquid biopsy was negative at 2 to 4 months versus they were positive, and what we can see that they do divide these patients very well. This was based on 46 patients. We are analyzing our 150 patients data, and let's see how the data looks like, and maybe there's a potential for it to become a good prognostic tool for prognosis and the future drug development. Now, can we leapfrog? When I was talking about these tests not being available, that is when I talk about having the biopsy and those intervention radiologists and those chest physicians who can get you the tissue. And I wanted to compare this telephone versus the cell phone. Yes, in India, the penetration of this regular phone was not more than 5%, 7%. And now you have almost everyone having a cell phone, because that's easily available and easy to handle. And that is where this liquid biopsy comes in as far as lung cancer is concerned. More and more I talk to my colleague. So sure, in tier 1 city, you do have a fair number of people who can get you tissue where you can do those various mutations for treating those patients. But moment you go to tier 2, tier 3 and beyond cities, it is very tough to get those people who can get you those tissues. So that is where I believe, in spite of having lesser sensitivity, there is a fair chance of this giving you a solution. Is it happening? Yes, this was done by my colleague who practiced in Patna, and it was so tough, and he was working in a government setup where it was so tough for him to get a tissue. Majority of the patients would not have a biopsy, and they say, hey, I can know this is lung cancer, I can get the FNAC for lung cancer, but then what do I do? And then he used to do liquid biopsy for these patients, and his reasoning was absolutely spot on. The sensitivity was less, but in those patients where it was positive, those mutations, the drug works as good as what it works in the patient having tissue biopsy. So this becomes a very good alternative for these patients in this setting. So for liquid biopsy in lung cancer, it is similar but less sensitive to tissue biopsy for molecular test. It is less tedious. The report is early to get. It is less invasive. It can be done in almost any place. And we need to explore liquid biopsy further in lung cancer. I do understand technology is a challenge, and we need to explore that more cost-effective technology for liquid biopsy may come in India, and that may have a good solution to the existing problem of tissue and also the future problem of many other questions what we have in lung cancer. And this also gets reflected in NCCN guideline, which suggests that at baseline, if you don't have adequate tissue, then you can do liquid biopsy for starting treatment for these patients. And in follow-up, liquid biopsy can be preferred to find out newer mutations as compared to tissue biopsy. And if liquid biopsy is negative, then you can do tissue biopsy in these patients. Thank you so much.
Thank you, Kumar. Excellent talk, and I could see tons of data. So a couple of questions. What do you think, because you have discussed about the liquid biopsy in lung cancer, and I have seen this, that when you compared with the sensitivity compared to primary tumor, you believe that liquid biopsy may not that sensitive in particular lung cancer based on your data. Is it the same scenario in other cancer?
So liquid biopsy overall is a bit less sensitive than tissue biopsy in general, and also it depends upon the tumor types, it depends upon the stages, and also it depends upon the mutation. For example, if you take EGFR mutation exon 19 and 21, your concordance rate, so sensitivity is almost around 90% and beyond. If you take T790M, the sensitivity goes down to around 70% and below. So, idea is that we need to explore this technology tumor by tumor, stage by stage, and mutation by mutation. That otherwise we'll keep getting some surprises, and then that technology loses the credibility. That doesn't mean I'm saying liquid biopsy is not a good solution. I did say that NCCN guideline recognizes this as a one of the routine investigation in certain situations, but we need to do that work. I have seen this work of having 40,000, 50,000 samples, and comparing and clubbing all the tumors, all the stages, and all the mutations together. But as the time goes by, we realize, that's not the best way to do to convince our clinician and the patients. We need to, the approach now onwards needs to that we need to go by as subgroup as possible, to convince the people.
Excellent. So there is a question from Dr. Klaus Pantel. Again, he is asking, first of all, great talk. So the comment is amazing. And the question is that, what is the sensitivity for detection of brain metastasis by liquid biopsy in lung cancer?
Brain metastasis from liquid biopsy, no, liquid biopsy doesn't help in detecting brain metastasis. The other question can be that if you have a brain mets, do you pick up in liquid biopsy? I do have anecdotes where we have done it. Looks like when you have a brain mets and then to pick up in liquid biopsy is tougher. The reason I won't know completely, as apart from that, you do have a blood-brain barrier. People say when you have a mets, it gets broken. But for whatever reason, when we have done liquid biopsy, for example, what we do liquid, this I'm interpreting from the lung cancer patient where only had a brain progressive disease, that disease in the brain increased. And as compared to people who had the disease increase in the lung. And then when we compare the data for those detecting the mutations, it appears we detect more in when you have a progression disease increasing in lung and beyond. But if it is only in brain, then the chances of detecting the newer mutations has been lesser.
Excellent. So there's another question from Dr. Ali from Mahavir Cancer Sansthan. The question is that, do EGFR tests through both FFP block and FNSC slide as well? Do you get better result in FNSC? What is your opinion?
So in general, biopsy is better, but you do have, see, we do have smart people everywhere. What we want, do you get those 100 odd cells, cancer cells? It can be in FNSC, it can be in biopsy. What we know that by and large, you get 100 cancer cells more in biopsy than in FNSC. But if you do have some, smart radiologist, you have a smart pathologist who can get those 100 cells more in FNSC, yes, why not? You can get those, tissue more. I have my, molecular biologist, when I have sent pleural fluid cytology, and then they say, hey, I pick up good number of mutations in them. And when I talk to them, say, hey, those the cells we are floating there, they are more malignant cells, and we are able to pick up. So idea is to pick up those more number of malignant cells. I do agree. If you do biopsy and you have a lot of mixture of normal cells as compared to tumor cells, then you may have biopsy, but you may not pick up those mutations. So idea is that it's just that by chance that in biopsy you pick up more tumor cells. But I agree, you do have smart people doing very
excellent. Excellent.
So, Prashant, I just have one quick question.
Please.
Yes, hi, Dr. Sevanti.
Hello, Dr. Kumar. Thank you so much for
thanking you for all your help. I was at Muzaffarpur, for that institute.
I told Prashant.
Very kind.
So I'll ask you a quick question. First of all, I would just say you are a thought leader, someone who we all look up to every step of the way. And in terms of designing studies, in terms of leading a vision for a trial, and I'm sure even in liquid biopsy, there will be strategies that you will really bring forward, which would bring out an answer to the world from India's side. I just have a very mundane question for you. When you have a resistant pathway identified in lung cancer, for example, MET identified in an EGFR positive patient, and you are having the patient on combination therapy, and you retest in a liquid biopsy, if the patient progresses and retest in the liquid biopsy and there's no MET seen, what would you think? Would you still continue the MET inhibitor, or would you think that that clone is gone? A thing that I face in the clinic all the time.
Correct. So, no, it is a very tough question, and sure, for all, evidence-wise, I don't know the answer. My answer will be more from
what do you do in clinical practice?
Yeah. So I think so. I won't have in lung cancer. I won't have a guts to stop it because for me, that patient is doing good. That clone is suppressed. What I have seen in some patients, I don't know what is the best way to do. But I have seen that clone may come back. So I say till the tumor is suppressed, patient doesn't have a side effect, and the tumor is well controlled with the drug. I say if something is not broken, don't fix it. So continue the treatment. That will be my advice till now. Having said that, I agree with you. We do have a contradictory result for a T790 with osimertinib. If it goes away, prognosis is poor. But is that really true for MET also? I don't know. I don't know. So I'll say by and large, we know that if those mutations or the tumor is suppressed, which we think is MET mutation which was present, which has gone away, suggesting that the drug is working and it is controlling the disease, I'll prefer continuing it.
Thank you. Thank you. That was wonderful. Thank you.
Thank you, Kumar. So I think Dr. Sevanthi, you are going to take over.
Yes.
Thank you. Thank you so much.
Thank you. Thank you for gracing us. And now we move over to the next speaker. It's my pleasure to introduce Dr. Nipun Sandhir. Nipun is the medical lead for personalized healthcare in Foundation Medicine and the medical manager, regional medical advisor at Roche Medical Lead in Personalized Healthcare Foundation Medicine. Nipun is a thought leader, someone who I have leaned on for many interpretations of Foundation One results. And I've always found his viewpoint, his interpretation of the genomics for a patient and the amalgamation of all the results very niched and very well laid out. The other thing that really stands out about Nipun is his depth of knowledge of his subject. And one of the reasons I thought he was the most suited for this talk today, as he was searching for other speakers, I said, why don't you speak, Nipun? We would really like to hear you and your thoughts as you launch the liquid biopsy in India from Foundation One. We would like to hear what are your thoughts in launching this test, and how hopeful are you for where it is going to bring the field? So Nipun, the floor is yours.
Thank you, ma'am. Thanks a lot. It's a pleasure to be part of this meeting. Amazing presentations, wonderful speakers. Can I get, am I allowed to share my screen now?
Yes, please. Please go ahead and share your screen, yes.
So before I begin, I would like to thank Dr. Prashant and Dr. Sevanthi for allowing us to contribute to this event. I've heard a lot of talks and thoughts from thought leaders, so pleasure to be here. Today, I'll be talking more on liquid biopsy and clinical utility of comprehensive genomic profiling based liquid biopsy with a focus on lung cancer. Maybe we are circling around it, so I thought I'll also deep dive a little more. Before we start on our journey, I wanted to talk a little bit about a term that I've started to get more inclined to something called as tumor circulome. Essentially, it refers to the entire gamut of cellular or molecular components in the blood, or which can help inform decisions on cancer biomarkers. It's an exciting field. We see research happening on peripheral blood components like extracellular vesicles, circulating tumor cells. We've heard a lot about them today, and tumor-educated platelets as well. There are also nucleic acid components like ctRNA, which is getting studied. Tumor proteins are also coming and getting into more translational research. But the king of them all is ctDNA. Recent approvals from FDA highlight that ctDNA has made from bench to bedside. Of all the things that we have discussed, I think Dr. Govind Babu earlier highlighted that the fact that we lean on liquid biopsies is because traditional tissue biopsies do carry disadvantage. But the biggest disadvantage, beyond being pragmatic in nature of not getting access to tissue or the hassle associated with biopsies, getting a tissue biopsy, I think the biggest disadvantage is that for a liquid biopsy can actually give you a view of intertumor heterogeneity and even intermetastasis heterogeneity as well. This is a wonderful case which exactly alludes to that of a BRAF-V600E CRC patient, which developed resistance to treatment. And in fact, if they looked at tumor biopsies from different lesions, getting different mutational profiles, but liquid biopsy was able to capture them all in one. So while this is the dream, it may or may not be true for all our patients in general. ctDNA has gained momentum, and it's now coming up more and more, and we see its utilization or potential utilization across the patient journey and across multiple settings as well, be it population level screening, early stage and diagnosis, and even late stage, as we have been discussing in therapy selection and resistance monitoring. This is the most often question that I've been asked, so I thought I'll just put a few slides on this. So when we talk about comprehensive genomic profiling, what is it? Simply put, CGP is not a scientific term, it's more of a differentiated term. The way we tried to coin this term at Foundation was the fact that our test somewhere resides between a targeted exome sequencing and a targeted genome sequencing. So we do sequence coding regions for our selected genes in its entirety. However, we also sequence for introns as well to identify fusions. So the term of comprehensive genomic profiling came in. Essentially, it differs from hotspot approach because hotspots, we are only looking at the most frequent alterations. But as I'll highlight later on, the CGP approach actually helps detect not just all classes of genomic alteration, but even the existing classes a little better. How does CGP work? A little bit about that. I think the core crux is our enrichment approach of hybridization capture. Essentially, it's about how we bait for different genes using biotinylated probes. Of course, sequencing, you can see that even with a low depth read of 500x to 750x, we are able to give sufficient statistically significant results. But the key differentiation which comes with the panels is the bioinformatic pipeline. So you can have Illumina technology, of course, assessing and sequencing, but the difference comes in more on how your bioinformatic pipeline reads and detects these mutations. So with FMI, we have published our analytical validation of both our sequencing and bioinformatic pipeline back in 2014, which is published in Nature Biotech. How has this translated into patient impact is, as you can see, better identification across genes. Here I've highlighted a few data sets of frequent mutations that even today were discussed, like EGFR, HER2, ALK, etc. Yes, so talking about Foundation One Liquid CDX, so this is a recent, or I would say an enhancement of our earlier liquid biopsy panel called as Foundation One Liquid. The CDX tag now comes because we have a companion diagnostic label for 4 indications to start with. The way the test has evolved is now it's a 324 gene DNA based test, which also reports blood TMB, MSI, and tumor fraction. Essentially, tumor fraction is the tumor component of the cell-free DNA that is measured in the sample. A specimen is peripheral whole blood, and this test identifies all classes of genomic alteration, including copy number amplifications, indels, mutations, and rearrangements as well. Talking about Foundation, we do have now published validation study for our liquid CDX as well. This is published in September 2020. As you can see, the way we have tried to structure this is a little different to the traditional sensitivity specificity approach, is defining at how much limit of detection, we are able to call out with 95% certainty a particular mutation. As you can see, the test has been structured in a way that for 75 genes, we bait for enhanced sensitivity, for which limit of detection is low. For others, it is a little higher, and the specificity of the test is, or the false positive calling rate is 0. So we've reported that overall false positive rate has been 1 in 8,000 samples that were part of the testing validation study. Yeah, so the next question that comes to mind is if the sensitivity of the test is good, whether the liquid and the standard of care currently tissue actually holds, and how is it in different cancer types. I've tried to answer this question for non-small cell lung cancer by the data derived from Platan Health clinical genomic database, a study that, an abstract that was presented at WLCL in 2019, where 702 samples which had matched tissue and liquid profiling were evaluated, and as you can see that most of the alterations were measured at similar frequency. Key highlights would be EGFR T790M, measured better in liquid versus solid, and likewise met exon 14 skipping, which was measured better in solid versus the liquid. Also highlighting the fact that this was done on an earlier version of the test, essentially Foundation One Liquid, and we are now collating more data on the relevance of solid and tumor in the liquid CDX version as well. Talking about utility in non-small cell lung cancer, a few things. Of course, lung cancer is the poster child for precision oncology. We've seen multiple therapeutic targets emerging over the period of very few years, in fact. And a liquid biopsy test can help determine that. Dr. Kumar already highlighted that almost 40% of the patients, don't have tissue as an option to do genomic testing. We feel that liquid biopsy can help solve that trouble. Talking about a new space that we have introduced is blood TMB as a marker for immunotherapy. Of course, the first study that came out was a study by David Gandara and colleagues in 2018, talking about OPO blood data sets and how a T-zone response correlated with blood TMB, which was at 16 with a cutoff of 16. We further got more confirmation of blood TMB being a valid marker in MYSTIC trial. And further, one study which I would like to highlight is a study by University of Pennsylvania in Charu Agarwal's group, which have now even predicted blood TMB as a marker for even combination therapy, including immuno plus chemo or immuno alone. Which is a new insight, considering, I remember still seeing the ESMO slide of TMB-RIP in NEVO-AP study once revealed in 2019. Yeah, talking about, so one is, of course, immunotherapy prediction, but also the biggest highlight is, of course, targeted treatment. We have discussed quite a lot EGFR here, but I would also want to highlight the utility of liquid biopsy in measuring ALK. So this is the ALK arm of BFAST trial that was presented in ESMO 2019, in which the detection rates using liquid and solid, using a foundation's liquid biopsy were equal, so 5.4% detection rate, and even treatment responses were evaluated to be very similar. Another aspect, I think we have been discussing it, and Dr. Sevanti also, pointed this out, is the TKI resistance. We do have now quite a lot of TKIs in the lung cancer space, and the right question to ask is how to sequence treatment in those settings. I think comprehensive genomic profiling does answer those questions in general. So if you look at first and second generation EGFR TKI post-progression data, you can see multiple mechanisms which potentially may be targetable. And likewise, there's also new data coming out from FLORA study, patients who had progressed with osimertinib and MET amplification, EGFR secondary mutations in getting reported, and even ALK fusions to the tune of 1% being also reported as a resistance mechanism, and we'll see how this becomes important later. I also wanted to highlight this factor of NTRK. Of course, they are rarest of the rare mutations, but they are relevant in lung cancer. And with Foundation 1 liquid CDX, we are measuring all NTRK 1, 2, 3 fusions as well. I would like to close with this case study, as I was mentioning before, of how ALK fusion became a resistance mechanism to anti-EGFR TKI of a 70-year-old Asian female never smoker, which was diagnosed with lung adenocarcinoma. Initial CGP revealed an EGFR L858R. This was followed by the patient receiving a erlotinib and a PR of 12 months. Post-progression, liquid biopsy revealed a T790M mutation, was given afatinib and afterwards osimertinib. Post-osimertinib progression, this patient, in fact, did a blood-based test and revealed a PLEC-HA7 ALK fusion, an in-frame fusion, and targeted with alectinib with osimertinib. And as you can see, the response highlighted in part B of the figure to the combination treatment as well. So with that, I would like to close by saying that patients who have whose tumors are anatomically inaccessible, their time sensitivity is a challenge. Patients with whom traditional biopsies are insufficient, we do utilize a lot of tissue initially for standard of care testing. And for patients whom we are looking for options after targeted therapies relapse or immunotherapy relapse are prime candidates for liquid biopsy, at least in lung cancer setting. With that, I close my talk. Back to you, Dr. Prashant, and thank you once again.
Thank you. Thank you,
Thank you,
Nipun.
Dr.
Thank you. That was a wonderful talk and very comprehensive. I will quickly ask a couple of questions. We are really running behind, but I have some questions for you. One is when we have a limited disease in a patient, we struggle in terms of liquid biopsy also. In that situation, do you recommend doing longitudinal testing, repeating the liquid biopsy? Does that give yield? Let's say the patient doesn't have anything positive in the current testing and you wait, the patient then progresses but doesn't have a whole lot of disease. Would you still go ahead with the liquid biopsy, or would you be hesitant in that particular cancer? So essentially the question is, does the type of cancer matter, or does the tumor burden itself matter?
So two things.
Or a combination of both.
So two things here. First and foremost, you are absolutely correct that there are published studies which enumerate that ctDNA load in certain cancer types is low. So we have to be very mindful of that. Second, in this particular case, if the patient has a low disease burden and we are not sure of the tumor will be shedding a lot of ctDNA, where there is either, the patient has a stable disease or just about to progress. One way for liquid biopsy to help out with this is to see if you're getting a ctDNA yield, it may be an indicator of patient progressing faster. Another way, if you're looking at sequencing the treatment, probably not the right approach, because in this we may not get an enough ctDNA yield. So this is my two-pronged answer.
Okay, great. The other question that I face most of the time is when we do liquid biopsy in a patient and you pick up an allelic frequency, which is variable allelic frequencies for different alterations. And let's say there are 2 alterations or 3 alterations that may be targetable in different ways, and you have different allelic frequencies. Do you just look at the percentage, or do you look at the percentage of allelic frequency for that particular pathway and then interpret the results?
I have a very different view on allelic frequencies, which is quite contrary to most of the available views that allelic frequency can help decide sequencing treatment. For me, I think it depends upon the gene. If the gene is driver, if I see an EGFR T790M in that particular profile that you mentioned at even 0.4%, I would go for osimertinib in that case. It's contextual in a way, but allelic frequencies can help determine it to a certain extent. However, if we see a strong driver, I would suggest probably to look at that more carefully before determining the treatment rather than looking at just maps. Because in a liquid biopsy setting, maps are indicative because you're looking at a global view and not definitive view of how cloning is happening at the site or at a metastatic lesion.
Fantastic. Thank you so much. That was very...
Sevanti, Dr. Govind Babu here.
Yes, sir,
for your previous question.
Yes, sir.
There is a recent paper in Nature Medicine talking about genome-wide cell-free DNA mutational integration, which can look at analyzing tumor fraction DNA as low as 10 to the power of -5. So this can get over the problems that we have of low circulating tumor DNA. So this is just published some time back, and I think this gives a lot more information for us.
Thank you. Look forward to the implementation. Thank you, sir.
Yeah, that is the important thing. Yes.
Thank you so much. And Nipun, thank you again for a wonderful talk.
Thank you.
Back to Prashant for... Thank you.
Thank you, Nipun. So we will move forward now. So our next speaker is Dr. Ram Prasad. The team, can you put his introduction slide? Yeah, thank you. So Dr. Ram is the Chief Executive Officer at MedGenome. Ram is actually working with MedGenome since its inception, and spearheads operation and strategy, I would say. I would also add that the RAM is the driving in building the diverse genetic testing portfolio at MedGenome. Dr. Ram has contributed immensely in craving and developing an evidence-based market for genetics in India. And it is my great honor to welcome Dr. Ram Prasad. Today he's going to talk about ctDNA and identification of novel target using liquid biopsy compared to tissue-based NGS. Dr. Ram.
Thanks, Prashant. Thanks, Dr. Sevanti. Pleasure to be here, trying to understand everyone's perspective and what you're all doing in clinic, in the labs. I think it's a thorough learning experience for us. So try to go fast as it's too late for many of us. So here we've been working in this from 2013, and I still distinctly remember in 2014 as giving a talk about liquid biopsies based on our experience with non-invasive prenatal testing.
Ram, can I just interrupt? We cannot see you. Could you please mind?
Sure.
Yeah, thank you.
So, so I was telling 2014 when we're talking about based on our experience with non-invasive prenatal testing, we were pretty well confident that this will extend into the oncology field, and was giving a talk in Mumbai Oncology Conference, and many of the oncologists, if not all of them, sort of doubted the kind of liquid biopsies application in the present context what we are talking now. But coincidentally met a couple of them, including Dr. Kumar Prabhash, Dr. Govind Babu, who supported us some of the studies. And I'll show you some of the stats, basically what kind of panels we do on the liquid biopsy. So we know that there are many guidelines coming up very fast, ASCO, ESMO guidelines, everything recommending liquid biopsy as one of the guiding for treatment decisions, especially with advanced tumors. And I stand vindicated here after the 2013 experience. To be very frank here, at this point of time, our view is multi-analyte needs a lot of resources before it gets matured into the clinic. You know, we might be slightly different approach compared to others. But I personally firmly believe that ctDNA and I don't think any of us have talked about the methylation that is investigated in the cell-free DNA, which is a very powerful way of identifying tumor cells and how the tumor pathways go, especially in the pre-symptomatic testing. So the blood and plasma gives us a fantastic resource to analyze all the analytes, especially the cfDNA, which has been discussed so far. And interestingly, if you compare with the imaging techniques, which needs about 1 billion cells to identify a tumor, liquid biopsy needs about 50 million malignant cells to get the sufficient cell-free DNA that can detect mutations pretty well. So in that context, it becomes very important that wherever possible, wherever it's rationally possible that we use liquid biopsy, we should use it. And also, one of the things which is extremely important is the tumor heterogeneity, which is usually there in majority of the tumors, especially the small tumors in different stages, which can lead to some of the false positives or false negatives, can be corrected by liquid biopsies, which will give you a complete picture of the tumor without any kind of heterogeneity present that's seen in tissue samples. Again, this has been discussed. About 31% of the patients in non-small cell lung cancer do not have accessible tissue. This becomes a fantastic source. And today we do about anywhere between 30 to 40 samples every month for patients who don't have accessible tissue at all in the non-small cell lung cancer. And it's the best alternative after the tissue testing is not there. And of course, in identifying secondary resistance, especially in mutations like T790M, you don't need fancy large NGS panels or multi-analyte testing. You can do a simple COBAs or simple droplet digital PCRs to identify these resistance mechanisms to quickly give, whether it's an osimertinib as a first-line treatment, or when it's an acquired resistance, you wanted to give osimertinib and stop the first-line therapy. This is something I always amazed. This is a classic deletion of exon 19 EGFR on liquid biopsy. I don't see any difference here between what we see in tumor and what we see. In fact, many times the cell-free DNA sample is so perfect compared to the slightly degraded FFPE DNA. So in that way, this is a fantastic sample source if we have the methods and algorithms that can detect very well, much better than FFPE DNA, which is almost most of the times degraded. And again, the tumor monitoring side, this is a paper which always I cite, is kind of a treatment changes that happen in a patient, in a breast cancer patient, the moment they saw a disease progression based on cell-free DNA using PIK3CA mutations compared to the CA antigen and circulating tumor cells. While circulating tumor cells are a very nice way of doing things, but still the sensitivity and also the prevalence of these circulating tumor cells in many of the situations is not as great as cell-free DNA. So still the cell-free DNA in liquid biopsy remains to be the first line as to how we wanted to test it. So this is in 2014-15, we started a study with the Tata Memorial Hospital. Dr. Kumar led us on this, and again, always thankful for his support. This is one, I think he has also shown this. We wanted to compare the classic RT-PCR on the tissue sample with a blinded study. Took the samples, about 101 cases, where we found about 23 cases which were positive by EGFR RT-PCR testing for exon 19 and exon 21 and L858R for 8 cases which were positive. And we wanted to see whether there's a concordance. As far as I know, this was the first study, which was a small one. But again, the stats were shown by Dr. Kumar earlier, and we published this paper. And from then, it's been, I think the field has been moving extremely fast. I don't think in any of the precision medicine, even compared to exomes in NGS germline, I think the way liquid biopsy and tumor profiling is moving is one of the fastest way field that's moving as far as precision medicine is concerned. So these are some of the stats that we have currently, some targeted hotspot panels, which we do routinely for non-small cell lung cancers, especially for identifying T790M mutations apart from the regular activating mutations. A pretty high number of samples we get for that, apart from NGS panels where we see about 32%, 30% of them. And 50 to 55% of these samples we have identified mutations using simple either droplet digital PCRs or COBAs, which are not very expensive. It costs you about 6,000-7,000 rupees or $100. And the multi-gene panels also give us a good diagnostic yield. So it's becoming a routine, creeping into the regular practice of an oncologist, trying to, based on these results, giving the treatment. So whatever studies, all the groups across the world, everyone, including in India, people have been doing, I think they are pretty successful in trying to get this into the clinical practice. EGFR T790M is one of the most sort of liquid biopsy test today for non-small cell lung cancer because of the available treatment that is present. And this is the kind of frequencies we see for exon 19, 20, 21, as well as sensitizing mutations along with T790M. And it's very common that we get wherever suspicion is there, wherever treatment has not really succeeded initially, we end up finding T790M mutations, and it helps a lot for the patients. And all these are all liquid biopsies. And this is a distribution of various cancers we have tested using NGS multi-gene panels. Again, lung stands out pretty strongly because of various treatment options available. And breast is fast. In fact, I will show you a couple of slides on the PIK3CA mutations that we are doing here. We do get most of them for our CAP validated tests, but some of them we do on a research basis also because the patients are desperate, trying to understand if there are any actionable mutations present. And some of the variants we saw in non-small cell lung cancer using multi-gene NGS liquid biopsies, again, EGFR stands out. KRAS is there, even though TP53 is not actionable, sometimes prognostication can be done using these mutations which are detected in liquid biopsy. Apart from non-small cell lung cancer, we do get cases of either breast or in this case, it is metastatic prostate cancer. This is an interesting case of AR activating mutation, which is a well-reported mutation of L702H detected in cfDNA. And it is again well-reported that this mutation seen in cell-free DNA is shown to be associated with resistance in some of the drugs that are given for castration-resistant prostate cancer. So in such situations, it really helps for the clinician whenever we do on liquid biopsy when the tumor is not available to take treatment decisions. After the T790M, one of the fastest growing cell-free DNA-based targeted approach is the PIK3CA because as you know, NCCN and several other, including FDA, has approved the PCR-based testing for both tissue as well as cell-free DNA testing of PIK3CA mutations for PIK3CA inhibitor, especially the alpelisib, which is now being checked by various clinicians across the world, including India. And we don't see anything different. While we see some of the double mutants and triple mutants, it's very difficult to identify whether these mutants are present in cis configuration or trans on the real-time PCR or the COBAS or TheraScreen. We do the TheraScreen based testing. And on NGS, the advantage is you can easily identify whether they are present in cis configuration so that you can really suggest what kind of treatment they can do. On the PIK3CA1, this is the data, if I'm right, on about 80 or 100 samples. Totally, we don't see anything different compared to the reports well cited already. Exon 9 E545K stands out the highest number, about 30% of the mutations are there in this. Exon 20, again, the two mutations, H1047R and H1047L, they are the two most common ones. And these all constitute about more than 90% of the PIK3CA mutations which have been reported so far. So having said that, I think the Holy Grail, what we are looking at is, this is one of the landmark studies published by Dennis Lowe's group, the discoverer of cell-free DNA in New England Journal of Medicine. It's a very, very powerful study where they have screened 20,000 completely asymptomatic individuals and identified Epstein-Barr virus DNA in the liquid biopsies of about 1,100 patients or individuals. And they were followed up with a repeated testing. They found 309 were persistently positive. And then they took them, 300 underwent endoscopic examination, followed by several of them, including MRI. And they found 34 had nasopharyngeal carcinoma. So this is something that we will be looking in the next 3 to 5 years, which will take over the field. What we call as a pre-symptomatic or early testing rather than just for treatment or tumor progression monitoring. So this is something that this will revolutionize the whole field, and the way not only just looking at one DNA or RNA based analyte, but also multi-analyte testings are being coming up. It's just a matter of time that companies like Grail will come up with a routine test where you can identify multiple cancers much before, few months or few years before you identify the cancer symptomatically or clinically. So the biggest question here is, can tissue biopsy gradually be replaced by liquid biopsy? So we need to see. So again, my always comparison goes back to the non-invasive prenatal testing. This is a graph that you can see here, how the fetal invasive testings have significantly gone down, the red line, as the blue line of non-invasive prenatal testing has gone up. So this is exactly the analogy I give for even for liquid biopsies in cancer. If it's not going to be the same situation, but we will see the number of tissue biopsies going down and number of non-invasive testings coming up as and more evidence comes up that these testings gives a lot of value for the clinical oncologist and the patient. Thank you.
Thank you, Ram. Wonderful talk. And I have just a technical question. How challenging it is to work on FFP sample in terms of liquid biopsy compared to the fresh tissue?
FFP is, if you ask, especially in India, FFP is pretty challenging. Again, it depends on from which lab it is coming, how they have fixed it up, how the formalin fixation has been done, and how all the processing has been done. But most of the times whatever you do, how much ever you salvage, we see minimum 10 to 15% of the times you end up throwing away the tissue or say discarding or rejecting the tissue. So it's a major problem. But I've seen in general, samples from US, Europe, and a few other countries is much amenable because of some of the stringent SOPs that some of the labs follow. But even then, we see that the moment you start fixing in formalin and also fix the tissues and make it as FFP blocks, it is not as good as a fresh tissue or a fresh sample.
Excellent. Another question, just based on your experience, what do you feel that getting a longitudinal sample and interpreting the data, which I don't know how many you really get it, but does it make really difference in the clinical practice, the way you identify some of the mutations on the primary tumor, or some of them where you have really the longitudinal samples? What is your opinion or what is your thought?
Prashant, this is longitudinal monitoring is growing in India. It has not picked up yet. Right now, it's more on actionability and treatment decisions. But we do have several cases. I distinctly remember a case of pancreatic cancer from Ahmedabad, a patient who spent quite a bit of money to just monitor. It was in stage 2, if I'm right. We identified a KRAS mutation. And we longitudinally monitored for almost about 1 year. I think 3 times we monitored. We could not find. Once it was in very low frequency, and 2 times followed by that treatment, we couldn't find the KRAS mutation. So we do see situations where people wanted to follow it longitudinally.
And have you experienced any success on CTCs based genomics?
No, to be very frank,
if you get it.
No, we are not. We've been very cautious in this field for various reasons, because the kind of studies you need to do if you want to bring it into a accredited, validated lab, the resources are extremely high, and we've been sticking to ctDNA.
Thank you very much, Ram. Thanks a lot.
So I just wanted to say both Dr. Ram's and both Dr. T. Raja's talks have really gone to the extended hour. Sincere apologies for that. That is the reason why we had placed your talks before mine, but then time requirements and then everything just went backwards. So really sorry for that. No. I think we'll turn to Dr. Sendurai Mani for introducing Dr. T. Raja, sir.
Thank you.
Good evening, everyone. Again, thank you all for joining the wonderful meeting. And again, sorry for the delay. Excitement, science, and the curiosity that kind of makes us go a little longer. But I hope you all are getting fed by wonderful knowledge. Thank you. So it gives me great pleasure to introduce Dr. T. Raja, whom I met at several occasions. He's a compassionate an oncologist and a great person. When I saw a poor kid who had a cancer, and I asked him whether he could see, and he right away opened the door and saw her and treated her for free. It's very rare to find people who are mostly compassionate, and thank you, Dr. T. Raja. And again, he's also an internationally recognized medical oncologist with 25 years of experience in the field of cancer. And he has vast experience in tertiary care setting. He's also academically very well known, and he's among the most sought faculty for national and international conferences and workshops. And he is the medical oncology, DNB medical oncology teacher and program head at Apollo Specialty Hospital. He's also head of the Department of Medical Oncology at Apollo Specialty Hospital, Chennai. He's a principal and co-principal investigator of several clinical trials. He published numerous papers in the field of oncology, And again, he's a wonderful host as well. I met him at two meetings which he organized, or he invited for both the meeting. He invited me, and he is an amazing host and a wonderful person. And without further ado, I will transfer the podium to Dr. Raja.
Thank you, Dr. Mani, for all the kind words you said. It's a great pleasure and privilege to know you and interact with you. And I have benefited with your interactions a lot. And I thank Dr. Prasant and Dr. Limai for inviting me to this meeting, and for taking precision oncology into midnight oncology. So hardcore people who thank you for this opportunity. But the problem is the topic, feasibility of liquid biopsy in India, how and when we use it. That's the topic Dr. Limai gave me. And after all the high-flying, high-tech talks, my trouble is to take it into day-to-day clinic, and how we have been trying to put this technology into use for our patients on a day-to-day basis over the past few years. I'll just walk you through, and if it's a very grounded talk, so pardon me for that. So as a clinician, what we would always ask is, where are the approvals and where are the guidelines? That's which guidelines approves, and how do I present it to my patients? And we all know that several liquid biopsy technologies are fortunately approved by the FDA. All the violet ones are the FDA approved EGFR mutation test V2, and then the PIK3CA RGQ PCR kit is FDA approved, and then the IDILA and the OncoBeam is EMA approved. And then we look at the NCCN guidelines and IASCL statements. These things comfort us. Okay, we have major approvals for putting this technology to our patients. Then comes the issue of whether the liquid biopsy is equal or concordant with the tissue biopsy. We have heard several speakers talk about it, but now we know the comfort level has increased, and we know that in the breast and in the GI malignancies, the concordance rate is anywhere about 80%, sometimes reaching up to 90%. And in a large study published by the Chinese group, the pan-tumor study, we saw that across all solid tumors, 28 tumor types, we have 75% concordance. So that settles the question, okay, there is concordance. And then we look at the question, which tumor I would order these tests. And the breast is an NCCN approved, and the esophageal, GEG, and gastric again are NCCN approved, and NSCLC, initial diagnostic and advanced metastatic disease, they are all NCCN approved. The colorectal one and the pancreatic one are soft now, the ESMO approved and possibly NCCN approved. So we have major approvals for initial testing in the advanced disease stage, and also sometimes for follow-up. We also know about the advantages of some of the unique advantages of the liquid biopsies over the standard tissue-based biopsies, that sometimes it can be more versatile. Particularly, we know that in metastatic prostate cancers, and also as presented by Dr. Nipun, it can detect diverging, resistant mechanism in different metastases in the same patient, and it can really educate us on, how versatile the resistant mechanisms in the same patient. And as we know, there are ongoing trials in the lung, the BFAST, and in the breast plasma match, and the chronos and the dynamic in the colon cancer field, and the PC bets in the prostate cancer. So that's the background on which I know that, okay, there are approvals, and these are the these are the tumor types wherein currently today I can order my liquid biopsy and then try to act on it. And as we heard, the MedGenome is one of the biggest provider in India. And what does the MedGenome recommend in their website? It recommends the liquid biopsy for patients in whom the tissue material is degraded or damaged or insufficient, non-availability, and when the clinical conditions are not suitable. So that's the premise in which it is set. Then looking at the data, contemporary data from our country is one of the early papers, as I was already pointed out. This is from partner Avinash Pandey and the group. And then we had the Tata group and the Rajiv Gandhi group publishing their experience on liquid biopsy. And once again, Dr. Prashant has done excellent work on circulating tumor cells, and he has numerous publications on this. And then again, some of our colleagues, particularly the Tata group, Dr. Anurag Chowgle, has extended the liquid biopsies to all the body tissues, and this paper was published just the end of last year, in which the pleural effusions and ascites and possibly CSF fluid was explored for the concordance of the epidermal growth factor mutation detection. So that's where the field is going. So we know that there are more opportunities, there are more ways to look at this particular technology, and how do I use it on a day-to-day clinic. That's always the question for us. What do I do for the patient in front? Few of our patients, how we used this liquid biopsy and biopsy technology, and how did we learn from that, on how did we act on this. For example, this patient who had a adenocarcinoma lung, who progressed on the standard PEM carbo. Initially, the tissue-based NGS did not reveal any particular mutation, but as the patient progressed, when we sent for liquid biopsy, because he refused for another biopsy, we found that he has got an ERBB2 mutation. And we discussed with him, and then we put him on the afatinib, and to our surprise, we found that he had an excellent response. And this is another patient who, on as everyone else has the experience, who on progression, when we did the liquid biopsy, you have the T790 mutation, and then responded to osimertinib. That's very, very understandable, and that's what everyone would do. There is another patient in whom in 2018, the tissue biopsy did not reveal anything particular as far as the mutation goes, but that was based on the PCR technique. That was what was available to us in 2018, and the EGFR, ALK, ROS, everything was negative. But as the patient progressed later on in 2020 early, because of the progression, then we had to send the liquid biopsy, because once again, rebiopsy was not possible. At that time, we find that this patient has got an exon 20 insertion. And based on this finding, then we put this patient on afatinib. And we find that this patient, this is in April 2019, and the patient response to afatinib has got a PFS of about 8 months with afatinib, but on progress. Then at this point, once again, this patient goes through another liquid biopsy when the patient progresses, and we see that this patient develops a new mutation, the T790 mutation. This is the longitudinal follow-up, and has still got the same EGFR mutation still on the display, and we have this EGFR T790 mutation emerging, and this patient was then switched out to osimertinib. Then again with osimertinib, we had another 8 months of PFS, and then when the patient progressed to once again clinically, when we repeated the liquid biopsy again longitudinally, what happened is the T790 clone was lost, and the original the original EGFR clone emerged to be predominant, and the T790 is gone by then. So the patient has lost the response to osimertinib, and based on this, at this point, this was in September 2020, we put this patient on a multi-drug ABCP regimen, and again to our surprise, for the past 4 months, the patient has already established a good partial response and has got an ongoing response. So this has taught us that there is a real utility in longitudinally employing this technique, and then if we get some information to act on it, and there can be still a clinical utility in this setting. This is another patient who at diagnosis lung adenocarcinoma, and has got both L858R and T790 mutation at presentation. So this patient had to be put on osimertinib, and the patient is still on osimertinib for more than 9 months. And this is another patient, a lung cancer, who on progression, when we initially did not have any mutations on the tissue biopsy, on progression, when we did the liquid biopsy, we detected the patient has got a ROS1 mutation. And based on that, we put the patient on crizotinib, and this patient is already on 8 months PFS ongoing with crizotinib. So these are our experiences with lung cancer, which is now a very, very accepted tumor type in which liquid biopsy can be used and can be acted on. And what about other cancers? These are our patients on breast cancer, in whom a patient who had lost the response to the endocrine therapy, who was on initially aromatase inhibitors and then CDK4/6 inhibitors. Then once we did a liquid biopsy, we detect the ESR1, and this patient, it has responded to fulvestrant as suggested by the liquid biopsy, and is on the fulvestrant PFS for the past 6 to 7 months. And this is another patient, as was already pointed out by some of our previous speaker, breast cancer with the TP53, which just was prognostic and we didn't have anything to act on. And there are some other difficult cases wherein we had to use the liquid biopsy, and whereupon we could find something to act on, but then we always also found that there are instances where we couldn't find a solution to that. I'm just presenting it for this very learned audience so that I can probably learn something from them. This is a patient, a young man who was only 19, who presented with a widespread disease, unknown primary, and was negative to everything, and had progressed on 2 to 3 lines of conventional chemotherapy, and we couldn't find anything specific to treat him. And then when we sent the liquid biopsy, we find that he had a PIK3CA mutation, and based on this, we put the patient on alpelisib, and for the past 4 months, he has got an ongoing response with alpelisib, and that's what is the experience. This is another patient. He's an 84-year-old gentleman in whom he had a lung cancer, progressive disease, and then we did a liquid biopsy. And we found that the patient had a BRAF V600 601 on the first instance in September 2020. But we thought this is this is not the class 1 mutation, and we did not want to act on a BRAF therapy just based on a liquid biopsy in an 84-year-old gentleman. We repeated it on October. But then what happened is October, we could not detect this. This was both from the Foundation 1. So then the patient gets a second opinion, and in Delhi, the tissue biopsy was repeated, and we found that the same BRAF mutation which was found in the first liquid biopsy was detected, and that was a good surprising concordance. So we put the patient on the doublet therapy. At age 84, the patient is responding beautifully to this doublet therapy. And but we don't always get lucky, like this. And this is a patient, CA ovary. We have a KRAS G12V and ESR1. The question that Dr. Lemay asked, sometimes when we have reports like this, equivocal, or when we have multiple alterations detected, we do not know what to do with these. And that's one of the difficulties with liquid biopsies. And this is another patient who had a squamous cell lung cancer, who had a PIK3CA amplification, which is again equivocal. Again, we do not know whether we can act upon this. This is another interesting patient. This is in 2017. That's when the Datar genetics, we heard about the excellent lectures from the Datar group. But in 2017, they had this to offer that is known as Cancer Track, in which liquid biopsy and CTC was offered probably for the first time in the country. And this is one of our patients in whom a very elderly male who had a lung cancer, and he was already 102 years at that time. And so we couldn't biopsy him, and then we had to do longitudinal liquid biopsies on that patient every 6 months for the past 3 to 4 years, and the patient is on. We didn't find anything specific in the mutations, and this patient, to our surprise, had responded to immunotherapy, single agent atezolizumab for about a year and a half, and then progress, and then we put him on doublet immunotherapy as a salvage with EP and Nivo combo, again showing a response for the past 1 year, and the patient is now 105 years, still doing well by God's grace. And this is another patient where a progressive lung with a liquid biopsy, where these information was absolutely not comprehensible, and wherein we didn't know how to act. But now I think Professor Levi has recently started a precision oncology clinic across the country. Probably we can present this in that kind of a tumor board. But then we didn't know what to do, so therefore we put this patient on a multi-drug ABCP regimen. Surprisingly, the patient is responding very well. So finally, what I want to say is that it's a very exciting technology for the clinician. I mean, it looks very, very novel and very useful, but there are challenges. And the next big challenge is what Professor Levi presented, that how do we get into multi-analyte assays and so on and so forth. I think the future is exciting, and it looks very expensive also. However, that's the way to go. Science, stops for nobody. Thank you so much for listening to me.
Thank you, Dr. Raja. This wonderful presentation. We have a question from Sneha. If patient's tissue biopsy was insufficient, would you order liquid biopsy or redo a tissue biopsy? Patient is hesitant to repeat the biopsy.
See, the conversation that happens in the clinic is whenever possible, we try to ask for a repeat biopsy, tissue biopsy. That has been the conventional approach. But we are becoming increasingly comfortable with ordering liquid biopsy whenever there's an appropriate setting, difficult biopsies, and when we want to serially follow a very elderly patient, clinically unstable, so on and so forth. And now, over the past, I have started using liquid biopsy for the past 3 to 4 years, from Datar to Quadrant to Foundation 1, which became FDA approved last year. And so we are becoming increasingly comfortable to do liquid biopsies, though we are still careful on which tumor type and which patient, and then get the information and then acting upon it. It's a clinician's challenge, but I think we are learning and we are getting there.
Thank you. Thank you.
Great thoughts. I just have one question, Mani.
Please.
So, there's a breast cancer patient that I'm treating, a triple negative breast cancer who relapsed very quickly. And we did Foundation 1 testing from her tumor tissue. And we didn't find any specific biomarkers. And she was, her SP142 was PD-L1 positive through Foundation 1. And with that report, we were able to start her on atezo and nab-paclitaxel. While we were going through, they also did a liquid biopsy testing. And in that liquid biopsy, she came back positive for PIK3CA mutation. And so when I was presenting to the Molecular Tumor Board Foundation 1, I presented this, and they were obviously concerned about the PIK3CA finding. And then it was confirmed in tissue also. So a separate tissue block confirmed. So this was clearly tumor heterogeneity, and this patient had that. So fast forward to a patient that I share with you. And this particular patient has a stage 3 lung cancer. And he got treated with you and then moved back to Mumbai. And he did a liquid biopsy. In that, he has BRAF, albeit low allelic frequency. And so obvious question came to me was why was I giving him durvalumab and not giving him a BRAF inhibitor? So I just mentioned these two cases to bring to light how would you take a decision on an alteration that was not seen in the tissue, because this stage 3 lung cancer patient had also done a tissue analysis which had not shown BRAF. And now fast forward to a situation where liquid biopsy is showing an alteration. So do you go back and check, or do you explain to the patient that there could be heterogeneity?
I'll try to answer, just by my experience, that's all. And for example, the lung cancer patient whom we treated, fortunately happens to be a loco-regional disease. And, so as of now, we are still following the concurrent therapy followed by, let's say, adjuvant immunotherapy. So we don't have to digress from that pathway. That's very clear. If and when he really moves forward, and if he establishes metastasis, then we are into a metastatic setting. That's when I'll start worrying about acting on those, let's say, the BRAF mutation. I may seriously think about that, because now I have in lung cancer, I have quite a few patients in whom the tissue biopsies have not demonstrated anything at diagnosis, and then on follow-up, we start to pick up all these, particularly the EGFR20 insertions and all that. And after initial hesitancy, after acting on them, I see that they are responding. And in fact, I presented that patient who had that EGFR insertion, that was about 8 months ago, to one of the leading lung experts across. And then all these trastuzumab, emtansine, everything was discussed. Finally, we all settled down afatinib, and we saw a gratifying response. So I'm convinced that we are seeing a mutation and we are acting on it. So it's perfectly okay to do. That's what I would advise you on both occasions.
Thank you. And just one last word about your 102-year-old patient. That patient has 9 lives because they lived through the single agent immunotherapy and then a doublet, which I don't think even 0.1% of Indian population has received. So kudos to your management.
I will show you, doublet rescue, that's when, and doublet rescue, we introduced doublet rescue that even before the 227 came in. The doublet rescue was introduced about 1.5 years ago, based on the conceptual idea. But of course, I had a discussion with the MD Anderson guy that you have a PD-1 inhibitor, atezolizumab. That was the recognized one for elderly patients where, so, and then patient progress on PD-1. So the logic was to go for an alternative, and then said, you try this, Nivo plus Ipi. We were really, really scared. But as it happens always, the son was well read, and he was totally with us, and he said, whatever you do, I'm with. So we said, okay, why not? And that was amazing. I'll send you the images of those patients.
That's an amazing illustrative case, learning for all of us.
Absolutely.
Ma'am, I would want to also maybe circle back to the previous question that you had. Maybe just a comment there. Is I would concur completely with Dr. Raja's comment about continuing with the current treatment. Just wanted to highlight one additional point there is with at least in metastatic lung cancer cases, we have observed that BRAF mutation concurs sensitivity to immunotherapy as well. So maybe at progression, BRAF becomes more of a point of concern. Right now, the immunotherapy itself is covering BRAF as well, at least if the patient is responding.
No, very well said. It's just that, Dr. T. Raja will know this patient is very detail oriented, and his question was actually very economic, that and also a convenience. If I can go on a pill, why do I have to do the IV? And also I feel economy plays a role. But
he's doing well, and that's for the future. So again, he will be convinced by the logic also.
Correct.
And I just take this opportunity to thank Nipun, because I really borrowed few slides from his earlier presentation. Dr. Nipun, sorry for that, and thank you for that.
Sir, they are yours, no worries. Education, it's education. Education is education. There's nothing me and you. Thank you for utilizing it.
Raja, there's Govind Babu here.
Hi, Govind.
Hi. The BRAF thing that you spoke about is very interesting. Actually, now there is data to say that the BRAF mutations are different in early stage versus metastatic disease. So I was actually thinking, why were they doing it in early stage? So now I'm just thinking back, we've started using TKIs for adjuvant. So probably in BRAF also the same thing might happen later on. So I think that is one thing we needed to keep in mind.
Thank you, Govind. And this was actually a progressed patient, and this was a class 2 BRAF. So we didn't dare to act on it first based on
that is true.
biopsy.
Yeah.
But then
That's
when
perfectly right.
tissue biopsy, to our big surprise, there was a concordance. That was beautiful.
Yeah.
So we decided to take the plunge.
Correct.
Great cases. Thank you.
Yep.
Mani?
Okay, wonderful. Yeah. It's a spectacular feast for this evening. And this shows the passion. It's not that you guys are not working for just profession. It's a passion. That's what I could see based on the time. It's too late. And there is one person here sitting on the call from Australia who's got the time is 3:40 a.m. It shows the passion, right? Our goal, what we want to do with. Oh, there you are. Right? It shows what we are trying to do with this life. While I'm sure we are all doing very well, but we don't have to. But you don't have to stay late to do what you do. But that shows every one of your passion and dedication, devotion to science, to humanity. Thank you all for that. So with that,
Australia and cricket, so we have to tell it.
All right.
With that,
everybody. Thanks very much.
Yes, with that, I thank Dr. Raja, Massimo Cristofanelli, Shamala Maheshwaran, who was there earlier, and Klaus Pantel, who was there, and Rick Thompson, who said bye. And thank you all. And then and thank you all, everyone from the Indian group, where it's a spectacular to learn, the amount of, again, the effort you are all putting into each patient, not treating as a disease, treating a patient rather than a disease, which makes huge difference. And thank you really. And I think Prashant and Seventy is going to continue the thank you for a couple of more minutes, just a few more minutes, and then you all can go to sleep. Go ahead.
Please.
Thank you.
Thank you, Mani. It was really a great evening, and we gone through a amazing evening. So I must thank Dr. Govind Babu, Dr. Ullas Batra, Dr. Nanda Rajneesh, Dr. Darshana Patil, Dr. Sevanti, Dr. Kumar Prabhas, Dr. Nipun, Dr. Ram Prasad, and Dr. T. Raja. Thank you very much for your time. Really appreciate, and you all may be surprised or happy to know that we got a really good number of participants, which we were not expecting. And the participants were not only from the clinics, there are many more from the university, research institutions, and many young students. So I definitely believe that it must be very motivating for them. And I would look forward for tomorrow's session and collecting more data, more understanding, and more revelation of the cancer biology. So I will hand over to Dr. Sevanti.
Thank you again, Prashant and Mani, for giving me this opportunity, and all the speakers for this wonderful academic feast. I just would like to thank my team here, just the housekeeping things, mainly because it's the students and INTAS that has helped us host this event. And my students are sitting in the next room. It's 11:30. And Prashant's student is sitting there and helping. And so Janani, thank you, Dr. Chetan, Aditya, Dr. Ruturaj, Dr. Prutha, Deepam, Dr. Ramya, Dhanashri, and the entire INTAS team, Ashish, Akhilesh, Anis, Amit, and Rohit. A big thank you to all of you. We did not take an event management team. We have hosted on our own. With INTAS's help to help us host, and also all the students. So such a pleasure and an honor to host you all this evening. And thank you, especially for the midnight oncology. Thank you, sir, for staying by. Thank you so much. And Govind Babu, sir, as well, for a very late night thing.
Congratulations to your team. Thank you.
Yes.
Thank you. Thank you.
Okay, guys. Good night. Good night.
Thank you all. Good
Thank
night.
you. Good night.
Stay safe. Good night.